Oh, sorry, kept you guys waiting in the waiting room. Good day to win. And Omar. Good day, Omar. Let me unmute you. Hello, Omar.
Hello, Dr. Bennett.
Hey, Dwayne, how you doing?
I'm all right. How are you?
Good. Okay, go ahead.
No, nothing. I just wanted to just got load shedded.
Okay, just watch what I do. Okay, Omar, how you doing, Omar? Unmute, Omar. Okay, you gotta unmute your microphone. Oh, I'll try. Yeah, you got it. Okay, I'll get it. Don't worry, we'll get it. Okay, can you hear me? Oh, no, you can't. You need to unmute, Omar. It should be at the top of your little icon there. There's an unmute button. And I'm gonna mute everyone else. Gee, I can't seem to unmute you there, Omar. I don't know why. Don't worry, we'll get it. Can you hear me, Omar? Okay. Yeah. Okay. Let me try to do it. Yeah. I tell you what, Omar, leave and come back, okay? reboot your machine and come back, okay? Can you hear me? Reboot, completely leave and come back.
Okay.
Oh, I can hear you now. Oh, go ahead.
Oh, yeah.
Okay,
Okay.
okay.
That's great.
Put it away, man. Okay, let me show you how to share your PowerPoint, okay?
Yeah.
Okay, now watch me. Okay, I'm gonna share. What I do is I go to the bottom of the screen. There's a share screen button. Do you see that?
Okay. Yeah.
Okay, let me do it. Only one person at a time can do it. So I'm gonna click that button and a screen comes up in front of me that shows me different screens that ask me which one do I want to share. So I pick one and I'm showing you something. I can take you
Yes.
anywhere. I can take you anywhere with that
Okay.
screen, including a PowerPoint. I can take you. So why don't you try that?
Okay. I'm gonna try to do that. Just let me send my presentation to Google Drive.
No. You screen share from your computer. Okay, click on the share button and go to your PowerPoint. Yeah, click on the
Okay.
share.
Okay.
Click on the share button first.
Okay, got it.
Okay, now
Okay, I will
now
try.
you own the screen. Take us where you want to take us. There you go. Open your PowerPoint, whatever PowerPoint it is.
Yep.
Open it up.
I'm on it.
You have low bandwidth, so you might have a hard time. I hope you don't have any
Okay,
videos. No, I don't see it. We don't see it.
You did? Okay. Wait a second. Now share. Okay.
No, you're sharing now. You're doing sharing, okay? But the PowerPoint's not open.
I'm on
Okay,
it.
can you send me, you don't have any videos. Oh, there you go. There you go. You got it. You see it?
Yeah, yeah.
Okay, that's what the internet sees right there.
Okay. And then
Yeah, advance.
I'm gonna stop sharing, and that's all.
Yeah, but let me see you advance. Advance in your PowerPoint. Like go
Oh,
forward.
sorry.
Yeah, no forward. Go back to your PowerPoint.
Yeah.
Click the share button and go to your PowerPoint.
Okay, I'm on
Let's
it.
do it again. Let's do it again.
Okay. Is that okay?
Yep, that's good. Okay, I'll go to the next slide.
You got it?
Yep, you got it. You got it. There you go.
Okay.
Now, okay, let me tell you what we have to do. You have a low, your bandwidth is not great. So if there's any problems, I want you to turn your video camera off. Okay, get off your PowerPoint now for now. Just put stop sharing at the top of the screen. It should say stop sharing. Oh, because I want to show you something. Okay, it says stop sharing.
Okay.
Okay, now at the bottom of your screen, you see the stop video and the mute button. At the far left, mute and stop.
Okay.
Okay, now watch what I do with my video camera. If I like, for example, if I'm in a place where the bandwidth's not great and I want to save bandwidth, here's what I do. You see what I did?
Okay.
I took my picture off because that consumes bandwidth. Do you know what I mean?
Okay.
So let me see you do that with your screen.
Okay.
And this, you just put, click on stop video. Stop video.
And choose virtual background.
No, it says
stop video. Okay.
Yeah, just click on that, and your video goes, and your face icon goes off. Like watch mine. Mine will go off when I click it.
Yeah, I said, but
you just click on the stop video. Click on that. It says stop video. Click on it.
Okay.
Click on the eye.
Okay.
Okay, that's good. You see how you can't see your picture?
Yeah.
Okay,
Yes.
but that does not affect your PowerPoint. It has nothing to do with your PowerPoint. So you can effectively present without showing your face.
That's good.
Yeah.
And then I can share my.
Yes, your PowerPoint. Yeah, you don't have to see your face.
Okay.
However, I want you to leave your face on unless we have bandwidth problems. If we start to have bandwidth problems, get your face off the screen. Do you know what I'm saying?
Okay. Yeah.
Because
Yeah,
that
it.
saves bandwidth. That saves it. So you'll learn this.
Okay.
You'll learn
Yeah.
this technology.
I got it now.
Yeah, you'll learn this technology.
Yeah. It's
That's
the first time
okay.
that
And
I used this.
yeah, I know. I appreciate you wanting to and I want to televise your Paris thing. I want you to tell the organizers that I'll televise their without going to Paris. I'll televise it. Do you know what I'm saying, Omar?
Okay.
Yeah. Hey, Joanna came. All right, from Finland. She's a neurosurgeon.
Sorry, I had some troubles with the web.
Yeah, that's the bandwidth.
Yeah.
You know, maybe you should turn your picture. Well, leave your picture on for introductions, okay? And then after I introduce you, just turn your picture off, okay? But I do want people to meet you and see you.
Yeah. Okay, I will.
And I think.
Yeah, I will do it.
Okay. Yeah. And don't worry if there's problems like your screen. Like right now, it's frozen. It's frozen. So we just wait and hopefully the bandwidth gets, you know what I mean? Or
Sorry.
That's okay. It's not your fault. I'm glad you're trying.
Yeah.
We try it here. I don't give up before trying.
Yeah.
So we're going to try our best and to do everything.
Yes.
Okay.
Okay, I agree.
Yeah, and we just be patient and wait. Sometimes the bandwidth gets better. Take your picture off. Sometimes it gets better. And we just methodically approach it. Hello, Joanna.
Okay.
Hi, John. How are you?
Glad to have you here.
Glad to be here. Thank you for having me there.
Well, you'll lend a little sanity to the proceedings.
Did I?
No, you will. You will.
That's good. Good to hear.
Okay, Kennedy and Rahul, we can introduce everyone, Omar, and looks like you may be going first, Omar, because the other speaker's not here yet.
Yeah.
Was it carefully planned? Nah, we're
flying. I see that.
We're flying by the seat of our pants.
Okay, then when you're ready, I'm gonna start.
Yeah. Give me it's about 2 minutes, okay? We're not real picky about times. We're kind of flexible. You have to be with people that are just starting to use it and stuff. So you can't be too rigid.
Yeah.
Okay, Zolo. Hello, Dwayne. Are you there, Dwayne?
Hello, I'm here.
I'm here.
Yeah, okay. Dwayne, listen, Dwayne. You and Zolo are going to lead the charge for medical school students from Africa. Do you accept the challenge?
Yes, Doc. Sure.
I can't hear you. Louder, louder.
Accept the challenge.
Okay, good. I want to hear it. We have to approach this though in a structured manner. Hey, Dr. Cabullo. Welcome.
Hello, Dr. Bennett. How are you? Hello,
Hey,
everyone.
nice to see you.
Glad to see you too.
Good. Yeah, well, you'll meet the speaker.
The video is the video available for the last presentation.
I just uploaded it to let me show you. Let me get you the link right now. I just uploaded it to the
People
YouTube.
asking about the slides, but unfortunately, wait a lot. I can't share it on email.
I put it on the Facebook and I put it on the website. It's a roughly edited video. It's not sent to Brazil yet. It's rough. So go to the Neurosurgical TV. It's right on the front page. That's the rough edit of the video. So, okay.
Is it also on YouTube?
Yes, it's on YouTube. Yeah.
Okay.
It's on YouTube. Go to the Neurosurgical TV. Yeah, I'll show you. Actually, I'll screen share. Okay. Okay, you see the YouTube, right? You see my screen, right, Dr. Cabullo?
Yeah.
Oh, I gotta put the link on there. Oh, wonder why it's not showing. Okay. I gotta take care of this, Dewen. And watch what I'm doing, Dewen and Zolo. I'm putting the embed code.
Yes, I'm seeing.
You guys get to see what goes on behind the scenes. I'm putting this on the front page of Neurosurgical TV now. Okay, we're in a hurry, so I can't really dress it up now. Okay, now we're on the front page of Neurosurgical TV, which you'll be able to see right there. You see us now, right? We're on the front page. That's us on the front page. But let me get off there. Okay, you ready to start? Ready to start, Omar?
Yeah.
Okay, let me get off my other sound screen. I shouldn't be on. Okay.
I'm ready. You tell me.
Yeah, okay. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. This is Dr. John Bennett for Neurosurgical TV. We have our third episode of Africa Neurosurgical Grand Rounds, and we're graced with the presence of Omar Antonio Gomez Valdez. He's a Mexican neurosurgeon that got in touch with me and wanted to present. So before I turn over to Omar, let's meet the guest panelists. Okay, Omar, let me just introduce the panelists, okay? Hi, Dr. Joanna, how are you?
Hi, John. How are you? I'm fine.
everyone.
Greetings from Finland.
Okay, she's from Finland. She's from Helsinki, Finland. We're
From
glad to have her.
Finland.
Yes,
That's great.
Yes.
yeah, it sure is. Okay, Dr. Cabullo.
Hello, everyone. My name is Kabulo. I'm from Democratic Republic of Congo, currently final year neurosurgeon resident at the University of Zimbabwe.
Yeah, he's been with us from the start. Hello, Dewen. Good day. Dewen.
Hello, Dr. Bennett. I'm Darwin Chimba, a medical student from Zambia, Copperbelt University.
Yes, and he's going to lead a channel for medical students from Africa to educate them during this time of the corona. Right, Dewen?
Oh.
Okay, very good. Kennedy, could you please introduce yourself?
Hi, John. You can hear me?
Yes, we can.
Okay. My name is Kimani Kennedy. I'm a third-year neurosurgical resident from Kenya, the University of Nairobi.
Oh, excellent. A friend of Khalif.
Yes.
Very
Yeah, I
good.
know
Well,
Khalif is a friend of mine.
we're welcome.
Yeah,
Okay,
thank you so much.
very good. Monir, I don't know if you're there. Monir, are you there? Perhaps not. Zolo, you're here, right, Zolo?
Hello, Dr. Ben. Hello, everyone. I'm here. I'm Zulu Ivan. I'm a CTA medical student from University of Buea in Cameroon. It's a pleasure being here. I'm a member of AFAN, and it's an honor to be here with you.
Well, Zolo had an audience with a legend in neurosurgery, Yuha, and he was bold enough to ask him a question. I was surprised, Joanna. Okay, Redme, I don't know what the name is. Redme, are you there? Or Aminata? Okay, Aminata, you're there, I'm sure. Aminata, could you please
Hello.
introduce yourself?
Yes, I'm Aminata, a neurosurgery resident training in Zimbabwe, from the Gambia and living in Namibia.
I know, it gets confusing, doesn't it? Okay, very good, welcome. And Rahul, can you introduce yourself, please?
Yeah, hi John. I'm Dr. Rahul, final year resident from India.
Oh, welcome, Rahul. Okay, very good, Omar. Thank you very much for taking the time to present, and it's all yours. Please say a few words about yourself first, Omar.
Okay, thank you.
Can you say a few words about yourself before you start?
Yeah. Well, I'm a fifth-year resident here in Mexico City from the General Hospital from Mexico. I'm a member of the American Association of Neurological Surgeons and the Congress of Neurological Surgeons too, and a member too of the International Society for interested in pediatric neurosurgery. So I published tumors in children. So, well, now I'm gonna speak about complications of CFS shunting in, well, with hydrocephalus in pediatrics. So let's get.
Okay, I just want to say one thing, Omar, okay, is that we're going to be challenged by the bandwidth. In situations like this, and we can be informal, and because this is, I'll just edit this out.
Okay.
But you know what? Maybe you should send me the PowerPoint. We should have prepared this before, and someday we'll get our act together.
Okay.
Can you send me the PowerPoint?
Yeah.
Yeah, just send it by email, right? You don't have videos in there. And then you just instruct me to go next. Do you know what I'm saying?
Oh, okay. Yeah.
Yeah, just send me. Okay. Yeah. Well, this is informal. We want to give the best we can give. So I think if you send me the PowerPoint and I'll share it.
Yeah. Just give me 1 minute.
Yeah. There's no hurry.
We
can always edit this out. And the live people, hello, they'll understand. We're just trying to do as good a job as we can.
Would you kindly send me your email or?
Yeah, sure. I'll do that. You can do it by
Facebook.
How about Facebook Messenger? Can you do it by that?
Okay.
Yeah, just send it by that.
Yeah.
Well, you guys get to see the dirty world of video, the back room. We know you didn't want to see it. This is an expose. Yeah, just send, please.
Okay, I'm on it. Wait. Damn.
No hurry, just send them as an attachment in your messenger.
Yeah.
It shouldn't be big, right?
Yeah, a little bit, not too much.
It's okay. No videos, all right?
No, there's no videos on it.
Okay, because that makes it impossible.
Okay. 1 second.
Nice. Oh, it's apple. Thank you.
Mhm. Hold on, John. Hold on.
Okay, no worry. No, don't worry. Well, this is like television. While he's working on that, let me
Yeah.
take, okay,
It's opening. Wait. Okay, let me try because I can send it to you.
well, how about you can
I don't know
email?
why.
Could you send it by email? You want to send it by email?
Yeah,
Okay, I'm
it's
gonna give you,
easier
yeah,
for
yeah,
me.
no problem. I'll put the email in my, in your messenger.
Yeah. Okay. Copy. Mhm.
Did you, okay. Did you get my email?
Yeah,
Okay.
I send it to you.
Oh, okay. Let me check the email.
Yeah. I have already sent it to you, so
Okay.
you tell me. It's the name is Shantz. You tell me. You got it?
Not yet. Okay. Let me send that again, maybe,
Okay.
okay, I still haven't got it. You try to send it again?
Okay.
Yeah, maybe, sometimes it get put in this trash.
Okay, we'll send it again.
No, it's not even in my trash either.
No?
No, not even the trash.
Okay. I will send it to you one more time.
Right. Oh, there, I got it. I got it.
Okay. Yep.
Okay, yeah, I got it. Okay,
That's fine.
let me get it.
Thank you.
Okay, I'm not.
Great.
Okay, let me try to make this big. Okay, I'm going to share it, and you have to lead me through the PowerPoint. Okay. How do I make this screen bigger here? Yeah, click slideshow, notes. Okay, is that
Okay.
sufficient? That's not the whole screen, right? Is
Yeah.
that screen okay?
Yeah,
Okay.
that's
okay,
fine for
okay.
me.
Is that okay, the screen?
Yes, yes, fine.
Okay, very good. Okay, why don't we start all over again?
Okay.
No, start from after the introduction.
Okay.
You can go
Here
right
we
into
are.
the presentation, okay? Start from the first slide. And start from the beginning and just,
Yeah, I'll go to the first one.
yeah, and then
If you want.
when you have the
Yeah,
next slide, just go
from
next.
the beginning. Oh,
And we just added all this out.
so from the beginning or
Yes,
from
please,
this one?
this from the beginning.
Okay, so
Go back to the first
hello
slide.
everyone.
You're not in the first
So
slide yet.
I'm
You're not in the
sorry.
first slide.
Yeah, okay.
Okay, there you go. Okay,
So
action.
hello everyone. Hello everyone, and I'm so sorry about it. Well, I'm Omar Antonio Gomez Valdez, and we are gonna talk about the complications of cerebrospinal fluid shunting, hydrocephalus in pediatrics patients. So next, please.
Okay, I'm sorry, Luz.
So as we know, there's a lot of diversion procedures to, well, among these most common neurosurgical interventions around the world. And the majority of these procedures are compromised of ventriculoperitoneal shunt insertions, as we know. We have a lot of patients that, well, with the hydrocephalus, so this is a common procedure. So in the United States, the annual incidence of this ventriculoperitoneal shunts placement is about 5% or 5 per 100,000, with almost 30,000 procedures performed each year. And that's why this is very important to talk about it. So next, please. So at 5 years following shunt insertion, we know that the cumulative complications rate at least was reported in general in 33%. And these complications may include malfunction or sometimes caused by obstruction, mechanical disconnection, or another mechanical affection, and sometimes infection on the site or along the trajectory of the shunt, and sometimes over drainage that may cause in some patients even hemorrhages. So this is why it's very important to know this. Next, please. Well, in pediatric population, we have the other one, please, John. Oh, well, that's fine. Well, the factors that are associated with shunt complications, we know that the male sex is used to present this, and we have too low socioeconomic status, younger age, like the newborn, and repeated shunt failures of obstructive, as we know, and low gestational age at the time of the first shunt insertion. Next, please. Good. Will you kindly pass to the other one?
Okay, then is this the next slide or this one? Is this okay?
So, and the heterogeneity in practice and complications. We're going to talk about heterogeneity.
Just hang in there. Sorry, folks, just be patient. Okay. Sometimes the bandwidth will slow things down. Be patient with this technology.
I have trouble with it. Sorry, John.
That's okay. It's okay. Just keep rolling.
Yeah. Well, as we know, the impact of shunt-related complications on the individual and society, it's important to recognize this heterogeneity, because we know that not all the patients had the same kind of two types.
Oh boy. Oh boy.
I don't know.
Sorry, folks.
Happening. One more time. In surgical decision making, that's very important, because as we know, in children there are many iterations or many types of hydrocephalus according to the migration of the neurons and for the cells. And that's why this team is very important, and we must know what kind of shunt we are going to use in these patients, because this is not always the same. Next, please. So in this image, we can see the CSF pathway we have in 5 stages, and we can see in the embryo, in the fetus, then in neonate, and then in infant. There are variations in the cerebrospinal fluid in these stages, and we must know this because cerebrospinal fluid will change according to the age of the patient, and according with this and other things in these patients, we're gonna choose what kind of shunt we're gonna use. Next, please. So in general, there's no consensus on the optimal methods of cerebrospinal fluid diversion, and the specific devices, procedures, and other protocols that we know should adopt uniformly to decrease the risk of shunt-related complications. What? Well, in patients who require an insertion of a ventriculoperitoneal shunt, we know that there are a lot of non-modifiable factors that may predispose to subsequent complications. Rather, we know that the pediatric patients had how can I say it? It's not complete the immune system. And they have a lot of predisposition to get an infection or sometimes an obstruction. Did you go out
I'm sorry.
from the slide? John?
I'm sorry. I lost the PowerPoint. I'm sorry. Production problem. Hold on, folks. Now I had your PowerPoint. I'm sorry about that. We're making all
Hello,
kinds
Dr.
of,
Ben.
we're making
Yes,
all
just-
kinds of,
Yes, Dr. Ben, just open the PowerPoint, click on it, show
let
the
me
function
stop
PowerPoint.
share. Hold on, folks. I gotta go back to your PowerPoint
Yep.
that I got from you. This is part of learning, folks, learning on the job. Yeah, I get to go. Oh, you sent it by email. Oh my God. Yeah, okay. Okay.
I'm so sorry for this.
No, that's all right. It's just part of learning. You know, wow, your email disappeared. The email doesn't have the attachment now. Okay, hold on.
Okay.
Oh, you gave me two. Okay. You gave me one there. Okay, there we go. Okay. We're back on track. Okay, let me share this and then we'll be ready to roll. Okay.
Okay.
Okay, let me get to the sixth slide, I believe it
Yep.
was.
Yes, and Dr. Ben, if possible, could you click on the last icon to your bottom right? Yes.
The slideshow?
Yes, Dr. Ben.
Yeah.
Oh, good. Oh, excellent. Thank you, Solo. That's why we paid co-producers.
Yeah.
Okay, go ahead. Oh, okay, which slide? Am I in the right slide?
I think that we were on the 7th.
Okay, you know, Solo, I can't see the
Seventh slide.
slides from here. Okay. Tell me when to
Next.
stop. Tell me when to stop.
Okay. Okay. I'm gonna tell you. Next one. I can see it. Huh? I can see it. I'm just saying heterogeneity in practice and complications. That's all that I.
Are you seeing? You're not seeing the PowerPoint?
Yeah. Next slide.
Okay.
I can see it, and I'm just.
You can't even see
watching the 5 one.
Can you guys see the PowerPoint?
It's not changing, it's stuck on one.
Yeah, it's not changing.
Page.
Okay, I'm changing it, but you're not seeing the change?
Nope.
No.
Okay,
No.
let me restart it again. Stop share. And I'll reshare it and see. Okay, do you see it now?
Yeah,
Okay.
it's far better. Thank
Yeah.
you.
Come back to. Go to one. Yeah, before.
Forward or back?
Oh, back.
Back?
Yeah. Back again. Okay. Here we are. So, I'm going to continue. So, heterogeneity also exists, like we know, in the underlying pathological conditions in this kind of patients. So, these are going to lead to shunt-dependent hydrocephalus. Not all the patients will have these ventricular shunts for his life. And next one, please. So this is very important. They may range from congenital malformations and such as an aqueductal stenosis or another variations like the patients who have myelomeningocele, as we know that they used to have hydrocephalus with this. And it's very important to know these underlying etiologies of hydrocephalus. So with this, maybe independently associated with poor outcome or poor health related, and they are gonna have another kind of complications according to the first etiology. Next one, please. So these malformations or alterations, we have part of a neural tube defect. As we know, the encephalocele and myelomeningocele are associated with hydrocephalus, and the other ones are part of a central nervous system malformations like Chiari-2, Dandy-Walker malformation, and all their variations. For example, we know that the Dandy-Walker malformation had a lot of malformations associated. And if we have another one like the holoprosencephaly and iradencephaly, who had a bad, well, next one, please.
Hold on. Okay.
Yeah.
There we go.
And the final one, the congenital aqueductal stenosis that may associated with an X-linked hydrocephalus and autosomal recessive and dominant forms. And the last one, the communicating hydrocephalus and all their variations in these patients. Yeah, next one, please. Next, please.
This one, next one?
Yeah, next one, please.
Okay.
Well, that one. That's good. I'm put this on this presentation because I think that it's very important to know all the midbrain and hindbrain malformations, because we, at least in my country, we saw a lot of patients with Dandy-Walker malformations and lissencephaly who had only one shunt, and we know that this will be very difficult to abort. We know that we can use sometimes two kind of catheters in supratentorial or infratentorial to abort these patients, because we know that in Dandy-Walker, for example, they have another cyst collection, and the pressures will be different in these patients. So the valve or the shunt that we are going to choose will be different if we found another patient with, for example, tetraventricular hydrocephalus. This is very important. We must know in these patients all these variations or malformations, and we must know what kind of pressure in the valves or the shunts we're going to use. Next one, please. Next. So on this image is just to represent another malformations. For example, we had these images of an enlargement of fetal pericerebellar CSF spaces, like we see on the images like B and C. We found an cerebral hemisphere abnormal with an small periventricular frontal cyst, and in the E and F, we found a periventricular cyst that as we see on this slide. Next one, please. Okay, thank you. Next one, yeah. Next, please, John. It's not changing. Okay, sure. And these are some examples of Dandy-Walker malformations. For example, on the letter E and H, we found a ventriculomegaly, and we found a cyst in, or a cerebellar cyst or infratentorial cyst that are one of the many variations of the malformations in Dandy Walker, and we must choose what kind of shunt we're going to use. And this is very important because if we just try to put a shunt at the supratentorial level, we are just gonna try to evacuate this cerebrospinal fluid at that level. And if we see these patients are gonna have a complication or an early complication associated with it, like mechanical complications. Next one, please. So I put this because it's very important to know in infants or children, according to the age, what kind of pressure they are gonna have in this cerebrospinal fluid. And we're gonna use this to try to put the shunt or the ventriculoperitoneal shunt according with this. This is very important in this kind of patients. Next one, please. This is just an example of normal human plasma and the lumbar cerebrospinal fluid components. This is not so important. Next one, please. And this is important too, like the pressure. We found the level of protein in the cerebrospinal fluid according to the age of these patients are gonna, well, it's gonna have many variations according with it. Like we see on the 0 to 30 days, we're gonna found to 20 to 150 milligrams over deciliter proteins. And this is, how can I say it? This is very different from an adult, because if we found this in an adult, we can suspect that he had an infection, and in this kind of patients, it's normal. So we must consider this if we think in complications. Next one, please. Next. So the procedure according to the valve and their indications. Next one. Okay, this according to, no, back to the other one, please.
Please talk about procedure, na?
Okay, we have this procedure and valve according to the type of hydrocephalus. We must consider this because in this kind of patients, like I said before, they have many variations and malformations. So if we are thinking in a standard size ventriculars, we're gonna use a programmable or medium pressure valve. And if we found some patients that are premature and the newborn, we can use a programmable set with a low pressure or a low pressure valve and a small counter valve. And in the large ventricles or chronic hydrocephalus, like in an adult patient, we can use a programmable or a flow regulated. And when we have one of these complications like the overdrainage, we can use a programmable flow regulated gravity valve or an anti-siphon devices. And when we had an obstructive hydrocephalus, we can use another kind of procedures, as we know, like endoscopic third ventriculostomy or another kind of cerebrospinal fluid shunt. And when we have a multiloculated hydrocephalus with an arachnoid cyst or a foreventricle trap, we can use the neuroendoscopy and another DVP with 1 or 2, like I said in the patients with Danny Walker, in a letter Y. Next one, please.
Sir, excuse me, sir. In pediatric patients with a large skull,
Do you see that okay? Is that the slide, correct slide?
Yeah,
Okay.
yeah,
in
the next one, please.
pediatric patients with
So,
large skull, where do you place the burr hole during shunting?
we can use one single borehole for that. We can use the classic the classic position when we put this shunt at parietal posterior. At least I like that because we put one catheter in at supratentorial level and another one connected to the valve, or the to the valve, and this another catheter is gonna.
My question is regarding the position of the burr hole, sir. Where do we exactly put the burr hole? Because pediatric patients, we get big skull with large hydrocephalus, big skull. So where exactly our burr hole should be there during tapping? It should be like Apuzzo's point or something like that.
I couldn't hear the question. Can you repeat?
Okay. Well, you know, why don't we get to the questions after the presentation? Why don't you continue, Omar? Okay.
Okay.
Yeah, just continue. We'll get to questions.
Yeah,
after.
that's fine.
Okay.
Okay, let's continue. So the causes of the several spinal fluid shunt complications. Next one, please. Well, we have the most common complication. It's the mechanical complications. We can find it in proximal or distal at the catheter, or sometimes there are fractures or catheter migration. We found this kind of complication in 8 to 64%. The second one, it's the functional complications, to 3 to 50%. Local infection in 3 to 12%, and the intra-abdominal complications like cysts at the abdominal cavity in 1 to 24%, and the intracranial hemorrhage like intraventricular, or sometimes complications associated like the presentation of a subdural hematoma in 4%, and epilepsy in 20 to 30%. Next one, please. Next one. Could you kindly change it, John? Thank you. So the symptoms and the signs that we are gonna find in these patients are too many. We found, for example, a headache associated with fever, nausea with collection along the shunt tract. We're gonna see an image of this. We found two feeding problems, lethargy, or we can use another scales to see this kind of changes. Abdominal pain, diarrhea or constipation, and sometimes are associated with a palpable intra-abdominal mass, and respiratory symptoms, which are one of the most important symptoms in these patients. And the most important is dyspnea, because it's an indirect symptom of or a sign of intracranial hypertension. Next one, please. Will you change the slide, please, John? Thank you. So in these images, we can see in this child skin rating along all the thoracic wall. Well, this is an indirect sign of an infection along the tract of this shunt. And in the letter B, we found another patient with all this subcutaneous accumulation of fluid. It's different from the previous photograph because we found it like in white. The tract is very different along this thoracic. Next one, please.
Oh, there's no next slide. We try
next,
another one.
please,
Okay, there
John.
we go. Is that one? Is that the right one?
Yeah, sorry.
Sorry.
Yeah. Well, we have one more time this kind of
forward
type of drainage system. We found another like the ventriculopleural, and we found these kind of complications associated with this. Next slide, please. And we know that there are another kind of shunts like the lumboperitoneal who have these complications like failure in recognizing complications over drainage, or the ventricular gallbladder, which is very rare to find feral patient related. And the most common, the subperitoneal and the cystoperitoneal shunts who had a lot of complications like cortical jam, loculated hydrocephalus with wrong position when we try to put the shunt on the posterior fossa drainages, like in the patients with Dudley Walker, when we can use multiple complications associated. Next slide, please. Next slide.
Is that the right one?
Yeah, the next, please.
The next one?
Yeah.
Okay.
We have that's fine. This with okay. Next one. Okay, another one. So in these photographs, we see in the left superior part of the slide, we found the CT scan with a bone window when we see this partial intracranial migration, and on the other photograph we found this image of well, when we are in surgery, we found this valve part grows around it. Next slide, please. Next slide. The next one, John. John.
Okay. Yeah.
Thank you.
Okay.
That's fine. Don't worry.
Okay.
On this photograph, we see a distal catheter dysfunction with a cirrus, occurring with a dew infection sorry. So we found this kind of infections as associated with in the distal catheter. So we found sometimes cysts that is abdominal. We must think in another kind of shunt, or sometimes we must use antibiotics and another kind of stuff to try to treat this, but it's very hard. And sometimes the patients had a bad prognostic. Next one, please. Next slide, please, John. So in this photograph, we see a patient with a shunt failure. This is a mechanical failure. When we found subcutaneous cerebrospinal fluid accumulation, like we see in the arrows, along all the shunt tract. Next one. So in conclusion, next one, please, Jan. Okay, we see that the most frequent complication of cerebrospinal shunting are the mechanical, and then the infections, and finally the functional. Next one, please. So it's not always easy to distinguish these kind of complications because we are talking about pediatrics. So the causing shunt dysfunction will be very hard sometimes to distinguish from another, for example, mechanical infection or functional. Next one. So another kind of complications that may present with a variety of symptoms and signs that we must know, or we must see in these patients. We must ask to the parents, or sometimes to get to the final diagnosis. And next one. Next. Okay. The clinical manifestations vary according to the patient's age and the etiology, like we talked in the first slides, and the etiology of hydrocephalus, and the cavity of cerebrospinal fluid drainage, and the type of valve or the shunt that we are going to use. Next, please. And next. So the final conclusion, we see that the appropriate knowledge of the mechanism that may contribute to in the production of the cerebrospinal fluid shunt failure, preventive measures to avoid them, and together with forthcoming will doubtless contribute to decrease the number and the severity of the complications. So this is something that we must think, or always that we see these kind of patients, or we think so. Next one. Well, and finally we have the references. So that's for these complications in this slide, and that's all, John. This is the final slide. We haven't, yeah. So one more time, I'm sorry for delayed and for this problems with my web, and
Yeah, you
that's
don't,
all.
thank you very much. You don't have to apologize for the technology because we're going ahead. We're just pushing ahead because technology will get better and we'll get, the power of the internet. I'm familiar with Mexico City. The internet is very, very challenging in Mexico City. I know about it. So I'm sure some panelists have some
Yeah.
comments or questions. Don't worry, you just had the courage to do that. I'm glad you got through it.
Thank
So
you.
any questions or comments for Omar?
Hello, Dr. Valdez. I'm Natalie Gomsi.
Hi.
Okay, my question goes to the shunting with the double valve that you said the why. How do you do that? I've never seen it done. So why is it that it is particular for the treatments of in case of, you said I think I heard word Danzi worker, and why is it that it is used mainly for that? Then the second question goes to, I once read on ventriculostomy usually associated with the cauterization of choroid plexus as ameliorating the outcome of patients, having a better outcome. What do you think about that technique, actually?
That technique, it's very useful when we have too many complications in the same patient, like infections, or when we had, for example, cyst in the abdominal cavity, and we don't want to put another shunt at the thoracic level or the ventricular trail shunt. We must consider that kind of procedure that you mentioned. Even if the patient had an infection, we must consider it because they can have a good outcome in the future, or maybe not. We have another percentage of failure, like 50% of failure with it, but sometimes it's the best decision to make that kind of procedure, and that's all.
Barhol.
Okay, more comments, questions?
Location of barhole in case of large hydrocephalus. Where do you want to put the barhole? Big heads. Any measurements, any such as that? Where do you want to exactly place the barhole when you are putting a shunt in pediatric patient?
Did you hear that question okay, Omar?
No.
No, I know. Oh, no, okay. Red Meat, we're having a hard time understanding. Could you text the question in the chat? We're
I
just
think
having
he
a
was
hard
talking about, are there measurements for the burr hole that we do for doing a shunting?
Yes.
The burr holes.
Yeah, the borehole. Well, the position of the borehole will be very hard to precision. We must first see what kind of patient we have. According to the age of the patient, we're gonna think about this borehole. Why? Because if we had a newborn, we know that the fontanelles are not united, and if we had another patient, for example, a 5th year or 7th year patient, we can use a parietal posterior borehole, for example. But in newborns, we can put this borehole. Sometimes I used to put it at the level where the parietal posterior sometimes, or we must use the CT scan to try to put this shunt. It's a very hard question, I know, because in newborns it's very difficult to put this borehole, and sometimes there are many variables variations of the procedure. And if we are thinking that we are gonna put another shunt connected with it, we can think to put another borehole at the occipital level. It's a very hard question, but I can send to you an article if you want, or I can explain myself with an image for you. If you wanna text me, I can send you the information because it's very hard to try to explain right now because there are many variations of that borehole according to the age of the patient. Is that okay for you?
Okay.
Yeah, put your email in the chat box and I'll see that Omar gets it, okay?
Yeah,
anyone
fine.
that, yeah, okay, anyone can put their email in there so that I can send it to Omar. Okay,
Dr. Valdez, I've got another question, please.
go ahead,
How do we
Natalie.
prevent most of those complications? What are the methods that we use to prevent them during the surgery or before the surgery, and even after it?
First, we must type we are gonna treat, and if we found in the CT scan or the MRI some kind of malformation associated, we must first see patient had another infratentorial malformation. We can use two variants of the shunt. To avoid that kind of complications, we must think in this first, so we can avoid the mechanical complications. Once that we found the most according shunt to put on this kind of patient and the pressure, we can avoid the mechanical complications. The infections are sometimes hard to prevent because there are a lot of articles that mention the use of the shunts with antibiotics or sometimes the use of the prophylactic antibiotics during the surgery and after that, but sometimes it's very hard even with it to avoid infections because we are talking about of the immune system of these patients are very primitive and infections sometimes can present, or if we use only one liquid to the same patient or the same surgeon, we can avoid sometimes infections, but it's very hard to avoid some of these complications.
Okay, very good. Dr. Gabullo, do you have any comments for Omar or questions?
Okay, thank you so much for that beautiful presentation. I just want to know if you came across the paper written by Professor Kalango about towards zero infection.
Sorry, what?
Yeah, he wants to know if you ever saw the paper by Dr. Kazadi. Dr. Kazadi, is that who wrote it? The paper, who was it by?
What paper? Sorry.
Yeah, don't worry.
I have some troubles.
Yeah, Dr. Gabullo, could you mention that paper again, please, that you mentioned?
Yes, I'm saying if he came across the paper written by Professor Kazadi Kalangu towards zero infection of shunt.
Right, Dr. Kazadi, zero infection of the shunt.
Okay.
Yeah, but they use the same personnel or the same doctors and residents equipped to treat these patients. And if we can have this in every hospital, we can avoid the infections, but sometimes it's very hard to do it because we must have the same nurse, the same doctor, the same surgeon at the same time to avoid the infections, and it's very hard to do it. And we must have the antibiotics and all the stuff in the same place. We, at least in my country, it's very hard to do it. So we just try to avoid the infections. For example, we use the same resin to treat the same patient and the other one and the other one and the other one. But then he get that or he avoid that complication just because he used the same equipment, the same doctors at the same time. It's very hard to do it.
Dr. Omar, do you test the shunt before placing it?
What?
Once again, Dr.
Do
Gabilla?
you usually test the shunt? You know, others are taking normal saline with a syringe. You test the shunt if it's permeable before you place it. Do you also do that?
Yeah, we used to test the shunt. Yeah, we used to do that, but we can get more infections if we do that. I used to prove the shunt only in adults, not in childs. I used to do that just in adults, not in these kind of patients, because like I said before, their immune system is very primitive and it's different from an adult patient. So I don't do that in these kind of patients.
Okay, very good.
Is that okay?
Hey, John, on that
Go ahead. We can hardly hear you.
I couldn't hear that.
Which one? Try again. Whoever asked that question.
Or you can text it.
Yeah, Kennedy, I don't think it's going to work. It's going to work. You can text the question. Okay. Redme refuses to send me his email, so I can't send you the information. Redme. Okay, Rahul, you have any remarks or questions?
Actually, Kennedy posted on the that.
Go ahead.
Is there any particular reason why the male sex is more predisposed than the female gender?
In general, I had this issue because in the male sex will or are predisposed to have more complications or more malformations associated, but there's no single reason that can explain why the male sex is more predisposed to this kind of complications.
Okay.
It's just because we found more malformations and they are predisposed to get another surgery to correct a mechanical complication, for example, and they will be predisposed to get an infection site.
Okay, more comments or questions?
His second
John.
question.
I'm sorry, you still explaining it?
Can Kennedy ask the second question? He wanted to ask if if he flushes the shunt system with antibiotics.
We tried that a few years ago, but we see that our patients, at least in our hospital, had the same predisposed to get an infection with or without the use of the antibiotic or the shunt impregnate with an antibiotic. For us, it's the same predisposed to get an infection with or without the antibiotic.
Okay, more comments. Hello, Roberto, welcome. You can't, late arrival. Musindo,
everyone.
welcome. Welcome, Roberto. Musindo, any comments or questions? Musindo is a common participant. He's from Zimbabwe, I believe. Okay, perhaps he stepped away. Dr. Manzer.
He's from Mozambique.
Mozambique, yeah, I always say Zimbabwe, Mozambique. Hello, Nihufar, I'm sorry to get your name wrong. Nilufar Tureva. Welcome. Okay, I guess Kennedy has a lot of questions. Okay, I think he has another question. Any more questions? And
yeah.
Go ahead, Kennedy. Loculated.
More question. Loculated cyst in the abdomen. How do you go about it?
Very good.
I've seen just one patient with that complication in 2 years. We treat this patient at first thinking in ventriculoatrial shunt, but we must think that this cyst sometimes it's contaminated or there's an infection on this side, so we can't put another shunt for the risk of infection in another place. And the antibiotic that we use sometimes, it's according to the site of the infection, and we we get the help of an infectology. So, and there's not a single antibiotic that we can use, but we can sometimes use vancomycin or another one to avoid a site of infection with a gram-positive. So, what about antibiotic impregnate? These kind of shunts that are impregnate with antibiotic are very expensive sometimes for our population or our country, and we don't use that, or we don't use this kind of shunts. Like I said before, we found many articles where there's, for example, we can say that a serious infection, but it's very hard to get that. Honestly, I doubt that we can get that serious infection in too many places or hospitals. We must have the same structure and the same equipe of surgeons to get that. It's very hard to do it, or at least I can't get to that zero infection in our country. It's very hard to do it. We have few patients with an infection site or an central nervous infection associated with these shunts, the zero infection yet. It's very hard to reproduce that.
Omar, I believe Dr. Corbulo had a relevant article that he wants to show you about Dr. Kazadi's. Go ahead, Dr.
Yeah,
Corbulo.
I saw it.
Oh, you did? Oh, you did. Okay. Okay. I thought you wanted to discuss. Did you want to discuss something about that paper, Dr. Corbulo? Because I know she put it up there on the board there.
The other one, antibiotics used. Okay.
No, I didn't want to discuss about it. I wanted just him to see this paper because the previous one was by Professor Schux, Maurice Schux from Hôpital La Timone in Marseille, in France. Then The next one was by Professor Kalangu, because Professor Shuk said you should reduce the number of whatever surgeons, and you don't need to get a scrub nest when you are operating you are doing the VP shunt to reduce the rate of infection. And also you don't test the shunt according to Professor Schultz. But Prof. Kalangu also is using betadine every time you are operating. Betadine, and he did that multi-center study, which showed the lowest rate of infection in the world. So I think the paper was very nice. You can go through it, you will see something nice.
You know, Joanna has some remarks. I don't know if you want to mention them, Joanna, or you want me to. Do you want to mention them, Joanna, from Finland?
Yeah, hi guys.
Go ahead.
I've only done VP shunting for adults, so that's why this is quite an interesting aspect to see. Also for pediatric patients, I was just wondering that in case of meningitis or peritonitis, how fast do you guys remove the shunt? How is it done in your countries? In Finland, it's usually so that the first surgeon basically shortens it as much as possible, and the neurosurgeon then maintains the cranial part. And antibiotics are done or used systematically mostly. Vancomycin and wide spectrum. How is it?
We use sometimes the systematic vancomycin just in one doses, or but we use this antibiotic just in patients with the infection already. We don't use this vancomycin like in prophylaxis, because we can get sometimes a resistant infection. So that's why we don't use the vancomycin in first line. We can use just
in case of meningitis or peritonitis. That was the only in those cases.
Oh, we can use vancomycin in meningitis, and when we have a cyst in the abdominal cavity, we can use sometimes to another antibiotics. I forgot the name. Jesus, it's sometimes meropenem or ertapenem.
Okay.
We can use many of those, but we used to prefer to go to the infectologist and present the case, and then he used to treat the infection appropriately. So we prefer to act before to put an antibiotic, to go to the infectologist to get a better treatment with these antibiotics.
Okay, there's a remark by Nilofar Tur-Eva. Do you want to read that remark, Nilofar, yourself?
Yes, if you can hear me. I just remember.
Okay, go ahead.
Okay. I just remember once Professor Chokes came to Uzbekistan and he gave his lecture, and he was talking about these shunting systems. He said there is no necessity of getting the expensive kind of shunts, Medtronic type of. We just at that time we used Indian ones. So he said it's okay to use it because it's evidence also showed that we need to change the shunt anyway after, like not anyway, but 50% after 2 years. So that would be anyway the shunt malfunctioning. And the second remark that he said is, of course, we need to use double glove in order to put the shunt. So when we were, it was just in his lecture, I do remember that.
Thank you.
Hello, everybody.
Go ahead, Zolo.
Okay, I have a question. I don't know if it's appropriate, but I wish to know, for example, assuming that there's a patient who has a shunt in place, a ventriculoperitoneal shunt in place, and the patient gets a peritonitis, like to say bacterial peritonitis. Uh, do we necessarily? I mean, what is the protocol here in this case? Are we going to remove the shunt of the patient, change it,
No, no,
or
no.
what do
Uh,
you do in that case?
you can put a ventriculostomy in the other hemisphere, for example, to put the ventriculostomy at the percoronal side and on the other side of the place where you find this complication. We don't use to remove the shunt because we can get another complication like an intraventricular hemorrhage. That's why we prefer to use a ventriculostomy to treat the infection, and we after that we'll consider to remove the other shunt.
Sorry, I have a question. Doctor, I have a question to Zolo. Zolo, what do you mean? That peritonitis, is it due to technique while placing the shunt, or it's just a peritonitis due to other things? The cause is other than the shunt.
We
Yes,
can remove the distal
Sorry?
shunt. We can remove it. You can remove the distal shunt, or we sometimes improve. We used to cut the distal catheter, and we closed the other portion of this catheter, and then collocate the ventriculostomy, because we cannot place another shunt, or for example, an or a ventricular trailer shunt. We cannot put this because we have not just a peritonitis, we have a systemic infection, and we can get one more time another complication, for example, endocarditis.
Okay, more comments or remarks from anybody? Eminata, you told me before, if I have a question, I'll ask it. But do you have any remarks or anything? Let me unmute your left phone. Hold on. I know that mute button's tricky. Yeah, you really got to stay on top of it. Go ahead. Go ahead.
Indeed, if I do have a question, I'll ask it. I'm enjoying the conversation and the discussion, and especially the mention of Prof. Kalangu's paper, which we are familiar with, and I'm glad it was brought up as well. It's a very useful paper. Thank you.
Thank you, Eminata.
Thank you too.
Okay, any other comments or questions? Okay, very good. Thank you for being patient with the technology, Omar, because as you can see,
yeah.
You know, it's a little choppy and the sound, but that's okay. It's better that you went through and you did it. I think it's
Next
better
time
than just.
it will be better.
Well, we'll all get better. I'll get better. All these guys will get better. Sometimes I talk for a few minutes and then I realize my mute button's on and no one can hear me. So anyways, so thanks everybody for coming. I'm just going to stop this and then we're going to start the next lecture. Okay. Once again, thank you, Omar.
Oh, thank you.
Okay.
Thank you to all of you.
Okay, great. Okay, Omar, we're going to continue on with the next presentation. Let's see here with Landry Conan. I'll start it officially in a second, and we're going to edit this out to make it clean. Hello, Landry, are you there? We've tried Landry before. We had some tech issues, but I think we'll be okay now. Are you there, Landry?
Yes, I am.
Okay, good. So what are you going to do? You have your own backup or something, or how are we going to do this?
Oh, last time we had a connection internet issue. So
Okay.
for today, I'll try to present, but I also provide the link where you can download the site just in case.
Well, I can't understand.
Yes, Dr. Ben.
what's-
Dr. Ben, I just sent you his presentation to your email address. So just check your email.
Okay, great. This is okay. You just be patient, everybody. This is what the good production teams do before, but we're not the best, but we're getting there. Okay, you sent that in my email, right? Okay. This is televising on the fly. Okay. Okay, here we go. Okay. A PowerPoint, right?
Yeah.
File is too large to preview. Okay, oh, wait, I'm downloading. Okay, I'll download it anyways. I can't scan for viruses. We'll try it anyway. But I'm downloading the PowerPoint right now, okay?
Good download. Okay.
Yeah. So on the way.
I just wanted to say that I got the course.
Okay, we're ready to go. Let me just introduce you. Hold on, let me let a few people in here.
Dr.
Okay,
Ben, we have a problem with sound.
everybody
The
needs to,
sound-
everyone needs to mute that is not talking,
Yes.
please, everyone. Okay, is everyone muted?
Okay.
Okay,
So John,
yeah, I haven't started yet. Okay, I haven't started yet.
Okay. You
Okay.
will just display and I will.
Hold on, I haven't started yet. Okay, now everyone with the mute button, pay attention to the mute button, okay? Because the camera will go to you if you're making noise and the mute button's not on. And it kind of disrupts the presentation. So be very cognizant of the mute button. And of course, when you share, unmute. So, okay, let me introduce you, Landry, and we'll start, okay?
Okay.
Okay, 10, 9, 8, 7, 6. We'll do it like TV. 5, 4, 3, 2, 1. Hi, this is Dr. John Bennett from Miami Beach, home of Neurosurgical TV. We have the pleasure today of having on the African Grand Rounds, Landry Conan, who is going to present and he'll explain the topic. But let's first quickly go through the panel. Part of the power of this platform is networking. Okay, let's start with Joanna. Go ahead,
Hi,
Joanna.
everybody. Hi, everybody. Greetings from Finland. Nice to be here.
Okay, what do you do in Finland, Joanna?
I'm a doctor
Okay.
in Finland. Yes.
Okay.
And
Okay.
on my own path to becoming a neurosurgeon.
A neurosurgeon to be.
Yes.
Great.
Nice to meet you.
Hello, Aminata.
Hello, everyone. Aminata Sala here. I'm a neurosurgical trainee training in Zimbabwe, originally from the Gambia, currently living in Namibia.
Oh boy. Keep fighting you to get through that.
I know, but I have to represent everybody.
There you go. You're representing half of Africa. Okay, Kennedy, could you please introduce yourself?
It's a good duck, but it's I'm Kenya.
Yeah, just barely. Yeah, okay. Kennedy's from Kenya, correct?
I'm the one that should be here.
Okay, let's move on. Omar, could you please quickly introduce yourself?
Yeah, I'm Omar Gomez, a fifth-year resident in Mexico City of neurosurgery and member of neuropediatrics of the American Association of Neurological Surgeons.
Very good. Welcome, Omar. And let's see, Rahul, can you hear me okay? Rahul from India. Perhaps he stepped away. And I won't say old Natalie. Natalie. Hello, Natalie, are you there? Once again, the old unmute button. Okay,
Yes,
go ahead, Natalie, go ahead.
hello everyone, I'm Natalie Gomes.
Okay, Natalie's got two microphones on. Okay.
Sorry, let me off one, okay?
That's okay. That's okay.
Okay, like that.
Go ahead, Natalie.
So,
Okay.
hello everyone, I'm Natalie. I'm a PGY1 resident in neurosurgical resident in Abidjan. Happy to meet you all.
And she was just a student when she started with us. But now she's a resident. Okay, let's see. Nilufar, could you please introduce yourself? Go ahead, Nilufar.
Thank you. Nice meeting you all.
Go ahead, introduce yourself. Go ahead, introduce yourself, please, Nilufar.
Yes, so sorry, I thought that you hear me. I'm the neurosurgeon from Uzbekistan. I'm interested in pediatric neurosurgery, so I would work in pediatric neurosurgery soon.
Great, great, super. Okay, Naru, could you please introduce yourself?
Hi everyone, I am Noru Din Bankal. I am in my 4th year of residency course. I'm from Benin, and I'm doing my training in WFNS Rabat Center, training of neurosurgery in Africa. And currently I am in France in the neurosurgery department of Tours CHU.
Okay,
Nice to meet you.
Big Anatomy Center and tours. Okay, and anyone else? Abba Dekar, Mohammed, if you want to introduce yourself, Hussein, Salim, Hadira,
Hello,
Galaxy.
John.
Go ahead.
Hello, everyone.
Go ahead, Musindo. Go ahead. I recognize your voice.
Okay. I'm Augusto Mosindo. I'm neurosurgery resident in Mozambique.
Mozambique. Very good. Welcome. Let's see. Anybody else that would like to introduce themselves? Okay, if not, go ahead. Go ahead.
No.
Or perhaps not. Okay, Landry, thank you for presenting, and it's all yours.
Okay, thank you. So can you display
Let me
my
make sure
slide?
everyone's muted. Okay, I gotta unmute everyone. Natalie, okay. I got your PowerPoint ready to go.
Okay, thank you. I just want to say hello to everybody, especially Professor Wale. She is our master. She's Professor of Anatomy and Neurosurgery here in Abidjan. So I have some of my mentors with us today. Professor Aida who is a neurosurgeon at the Department of Neurosurgery here in Ivory Coast, the biggest town called Bouaké. So today, my topic is about endoscopic endometrial approach that we do to get to the center and can use it again to go to the interior fossa, to the fibers, and even to the C1, C2 junction. So let's go ahead, slide please. So I'm Denton. I'm an assistant professor in University of Wayne, where I have a joint appointment in the Laboratory of Anatomy and the Department of Neurosurgery in Abidjan. Okay, the next slide, please.
Hello, Dr. Conan.
Okay, it's not going forward. I'm sorry. Let me try it again. Okay, next slide. Okay, there we go. Are you all set?
Introduction. Yeah, so I hope everybody can hear me. I'll try to speak slowly. So the transcranial approach is not something new, but the introduction of the telescope is quite new, and especially during the last 2 decades, where the endoscope gave us a bigger view of what we are gonna do compared to the microscopic approach. So with the endoscope, you have a wider panoramic view that will make you more comfortable to work and to have access to the cellar and all the regions. For us, an interest for this presentation is that this approach is commonly used by both ENTs and skull-based neurosurgeons. So for me, this is how I see this approach. Going through the sphenoid bone is what we call transsphenoidal approach. So with this approach, you can have access to the anterior skull base from the anterior fossa, middle fossa, and posterior fossa. So it's the kind of hub where you can go through all these regions. Next slide, please.
Okay, next slide.
So I will do, my first chapter will be about anatomy. So just a brief recall of what is essential for neurosurgery. After that, I will go to the indication, and I will take much longer time to explain the technique, the way I do it. Okay, before concluding. Can you go to the next slide?
Dr. Ben, please, can you make it a slideshow?
Oh, okay, thank you. Okay, the far right, right?
Yeah, this one. Okay.
Can you see it okay?
Okay. Okay, next slide, please. Okay. So this is what we're going to talk about. We put the telescope. So the telescope is these rigid rods that will direct us right to the sphenoid sinus. So as you see here, this is just one image that we used to see. But what I want to show you here is that usually people think about the nose as going like 45 degrees up. So when they put the endoscope, they go 45 degrees up, and sometimes they go too high that led them to the anterior fossa. So I will show you some of my tips in order to go straight to the center, going through the sphenoid bone. Okay, so this is the telescope that this we're gonna describe later. But let's focus on the anatomy. Let's go. Next.
Next slide.
Yeah, next slide. So if you want to go through the transsphenoidal approach, you need to be aware of the bone, arteries, and the mucosa. So that's what you're going to do. So on the upper left is a sagittal view where you can see. I don't know if you can pinpoint some of the thing I want to show. Is it possible, John? So here in green, for the sagittal view, what I want to show is an ethmoid bone. And before the ethmoid bone, we have this in yellow. This is the cartilage. QC is the cartilage bone. And below both bones, you have the vomer bone. So this is a mid-sagittal bone. Mid-sagittal bone that we need to be aware of. If you go straight, you will find the sphenoid bone. And in the midline, what we encounter is the sphenoid sinus. This is very important, a very important landmark. So below, you will see MB is a mandible bone. And up there, you see that NB is just nasal bone. And on the purple color, FB is the frontal bone. So as I mentioned earlier, you can go through the nose and have access to anterior fossa, middle fossa, posterior fossa, all from the anterior aspect. So when you go on the next next picture on this side, lower right, you will see that you go a little bit laterally. So you will see ethmoid bone again. You will have the middle turbinate and the upper turbinate. The inferior turbinate is just below. And all those will be a landmark when we want to go and perform this approach. So that's the bone you need to be aware of. Next slide. When we will put your telescope, sometimes we say telescope, sometimes we say telescope. I think people say that the audio is not clear. Hello?
Yeah.
John, can you hear me? What?
Yeah, I'm not hearing you. It's the same with everybody else. I can hardly hear them.
Yeah, I can hear you.
Yeah, Landry, can you hear me okay, Landry?
Yeah, I hear you okay.
Okay,
We
you're
don't hear you. Please to be close to your microphone. Please, we don't hear you. Maybe you are so far than your microphone.
okay. Go ahead, Landry. Go ahead. Let's try it. Yeah, can hardly hear you. It's the same problems last week. Well, wait, let me unmute you. Hold on. You were muted there. Hold on. Okay. Oh, man. Just hang on there. Hang on. We'll get better at this production. Okay, go ahead. Go ahead, Landry.
Can you hear me?
Yes, we can hear you.
So, I was saying that when you put your endoscope, one of the most complications that you can have is sleep. You need to be aware of the way the arterial blood supply goes through the body. So we have three main arteries that will supply this area. So on the top, you will see anterior ethmoid artery, the top anterior ethmoidal artery, and the posterior ethmoidal artery. Those are important, and it will do about 15% of the arterial supply. The main supply would be the stenocardiac artery, and this is what you see on the picture here. This is the maxillary artery. So the maxillary artery will give up the branch that will supply most posteriorly the septum and the lateral fossa of the intestine. So this is what you see on the picture on the right and again on the left. Three main arteries. Anterior, posterior, and middle artery on the top, and just at the bottom, in the middle, you will have the branch of the stenocardiac artery. So let's go to the next slide. So you need to understand because I will share some tips to avoid bleeding. So go ahead. Next slide. Next slide, please. Okay. So next slide. This is another very important. Okay. This one is good. So here is a coronal view of the nose. That when you get to the vestibule, to the nostril, you will see right away the inferior turbinate. So many people, when they get to the bone, to the reservoir, they try to reach the middle turbinate right away. Right? Okay, this is important, but you need to go step by step. First thing that you will see is the inferior turbinate. So just be sure to locate it and to identify it well. Next, you will go ahead, you will see the middle turbinate. The superior turbinate is not always seen, but you should not worry about it. Okay, and in the midline, you will see the nasal septum. And on the right picture here is what I want to show you is the ethmoid bulla. So the ethmoid bulla here is this bony structure that will sometimes make it difficult to displace the middle turbinate laterally. One of my methods, usually what it does is just he crushed this ethmoid abdullah and then he lateralize the middle turbinate. This is much more easier to go forward when you do this. So what you need to understand is when you put your endoscope, don't try to go 45 degree up, just go down. Once you get through the nostril, go down. You will see the floor, you will see the middle turbinate, you will see the inferior turbinate. And that's what you need to see before going forward. Okay,
Next slide.
Yeah, next slide.
Okay.
Okay. So this is a short video that we did. Can you display the video?
Okay. Hang in there.
First play. Go to the play button on the bottom left.
Oh, okay, you want to go to the previous slide?
Yeah, bottom screen. No, this one.
Oh, okay.
Yeah. It's a cadaver dissection when you explore the nasal fossa. Can you click on the video, please?
You're playing a video?
Yes.
No, we can't. No, we can't play. We can't play a video. We can't play a video because the video needs a lot
okay,
of.
Let's go to the next.
Yeah, the video needs a lot of bandwidth, which we don't have. Okay.
Okay. So please, can you go backward just a little bit? I just want to make one comment and go to this. Can you go back again, please?
Okay, you want to go back?
John?
Yeah, hold on. Okay.
John, you can go back on the video, just off the screen. That's you go back on it on the off the full screen, and then you can play the video.
Okay, this screen? What screen?
Off the full screen.
Which slide do you want?
Mode. Off the presentation mode.
Oh, okay. Okay, is that better?
Go back to the video that you wanted. The video.
Okay, so let me comment this. Let me comment this with CT scan. Oh.
Okay, which video? Which do you want? Which one do you want?
The 9th slide. The 9th.
Okay.
Yeah.
Yeah,
you can play the video now.
Play the video.
Oh, we can. I'm sorry. Okay, this one.
No, the previous one.
Okay, which one is the video?
The 9th slide. The 9th.
Okay.
Yeah, this one. Yeah, and if you double click on the video, you can be able to see. You see,
click on the
video, you will see about. Click on the black rectangle.
Okay, okay, we'll try it.
Yeah,
I'll be surprised if it works, but I hope it does. Okay.
Dr. Bennett, sorry. There is someone who is connected also on YouTube or on Facebook.
No, it's playing.
So if someone can be everyone can be on Zoom and leave Facebook and YouTube.
No, it's playing. It's playing.
It's playing.
Dr. Kabulo, let's try it again. Okay, we'll try it again. Okay, there we go.
Okay, let's do it. So
it'll start. There you go.
Okay. Once you get through the nose, this is what you see. You see on the right is the nasal septum, and on the back here you will see the anterior turbinate and the floor. Just here. So you see the anterior turbinate. You go straight. You go straight. You will see the middle turbinate up. Naturally, you will see the ethmoid bulla that you can just crush to make more space. To displace laterally the middle turbinate. Okay. So we will go down again. This is the cadaveric dissection of today. So this corridor is where you should go. This is where you will go. Okay, let's go to the next slide, number 10.
Next slide.
Yes, next slide. Okay. So this is again here. We are on the left nostril. The picture I, the first picture on the left. The first picture on the left, what you see empty is middle turbinate, and then so you are on the left nostril. So naturally to the middle turbinate is a dura equinalis that you can just destroy with just your punch or your rongeur, and you can make more space to move the middle turbinate lateral. Let's go to the next slide. Slide.
The next slide.
Yes. So the next slide, what I want to show you here on the picture, up, and left, this here is a right nostril. If you go to the right nostril, like I said before, you will see the inferior turbinate at the floor. You see the inferior turbinate to the left, you see the nasal septum to the right, and you have this corridor where you should do your maximum to increase. So to be able to have a wider space between the inferior turbinate and the nasal septum, is you just put cotton oil there. You just put some Codman patty. Okay. You put Codman patty or whatever brand you have. You put patties here that you soak in xylocaine with naphthalene. That's what we use here. That is available here. In some other countries, they just put they soak the patty into cocaine and they put here in the middle. So the effect when you do this is that you go to this small corridor, narrow corridor on the up left to a bigger corridor that you will see down right here. So here when you go down on this picture down right, you will see the nasal septum again, the inferior turbinate laterally, the middle turbinate just in front of you, and you will see the posterior rhinopharynx that you see on the bottom, that CO that you see. So for me, what you see here, CO down is the most important landmark. This is the most important landmark because it's easy to see. You just put the endoscope, you go, once you get to the nose, you go down, you go straight, you will see.
Okay.
This
Okay.
kind of arc.
Oh,
So
hello?
let's go to the next. Hello?
Landry, I think we have to cut this short because the connection is just not good enough because it looks like a quality presentation. What we're going to do is we're going to cut it short now. We're going to finish it next week, okay? And in the meanwhile, we're going to look for an internet connection that is better so that you can present these excellent slides. We want to see them, and we're really not getting any audio. Okay, so we're going to continue this. We're going to. Is that okay, Landry? I'm sorry to do this, but we really need to have a good presentation from you. You put the work in, you did it. So we're going to look for a good internet connection next week and do justice to your PowerPoint. Does that sound like a plan?
Okay.
I'm sorry, Landry. I'm sorry, but it's just the audio is just too inconsistent, and it's you know, we should have checked before, but as I said before, we're learning, and this is our mistake, production mistake. I should have checked the connection before, et cetera, et cetera. But that's something we're going to learn with this technology. But I'm glad we didn't make the mistake of not trying. That would be a mistake if we didn't try. So everyone, we're going to be back next week, and Landry's going to present again. We're going to find a better bandwidth for Landry. And any comments or questions from the audience? Was that the right decision? That was a corporate decision. And you know what, Aminata, I can't get fired because I'm the boss.
The slides were really fabulous. The images were fantastic, and I'm looking forward to when the whole presentation comes together. Can't wait.
Yeah. Well, you know, he had 65 slides, and I didn't want to put you guys through that for 65 slides. I don't think it would have been a good idea. But yeah, we'll get a good one and do it justice, do that presentation justice. So I thank everybody for coming. Any other comments, you guys? Do you have anything that you want to comment about? Whatever.
I don't know.
Well, Landry, go ahead. Yeah, go ahead, Landry. Go ahead.
Yeah. So is it that I need to change my location, or I need to reduce the slide? Or,
well, we need to. Okay,
should...
let me show you. And actually, this would be an education for the people with us here. And I'm going to show you what the things that we should have done. Me and my warriors were sleeping, Zolo, during the battle.
Or maybe I can change my headset.
No. I think what you could do, maybe you have an iPhone.
Yes, I have an iPhone.
Okay, maybe you can go in through the iPhone to Zoom. Okay, can you do that? Let's try it now. Maybe we'll be able to rescue this. Go into this link. Go into the link to come in this with your iPhone. Do you know what I'm saying?
Yeah. I'm trying right now.
Yeah, you might have to get off your laptop, but go into your smartphone, and you could use that for audio because smartphones can do audio. And you could just.
Okay. I could use that.
You might have to.
If I do audio, I can still use my computer to see the file.
Well, the audio might get better with a smartphone. In other words, leave this you're doing on a laptop, right?
Yeah, so I leave the laptop.
Yeah, leave the laptop, go to your smartphone and come into the webcast with the link again through your smartphone.
From the laptop.
Yeah, leave this and come in through your smartphone. And we'll all see this is a living test. Yeah, you haven't left that. You're still there, Landry. You need to leave. You need to leave and come in through your smartphone.
I'm leaving.
Okay, okay, there we go. Okay, we get to see if this works. Real life testing. Because I give presentations from his smartphone all the time. And he doesn't break a sweat.
I think maybe it is the laptop who is not so good with microphone. Maybe with his phone, maybe the sound will be better.
Yeah, let's try it. Let's try it. We can try it. I don't think it's going to get worse. But I don't know about you guys, but I couldn't understand a lot of what he was saying, unfortunately. But that's part of what, we're learning production. That's part of what DeWin, Zolo, and I should do is before the presentation, we go to the person, we do a rehearsal. So you're not only rehearsing the material, you're rehearsing his audio connection and video connection. So you make sure the camera is all right, make sure the audio is okay. And then you go from there. Okay, let's see. Hopefully he's trying to get into his smartphone. There, he's okay, coming into his smartphone. This is a real life test. Landry, can you hear me? Go ahead, Landry. Can you hear me, Landry? Oh, I thought he was in there. Oh, there he's in.
Unmute yourself, maybe Landry. Unmute yourself.
No, he's unmuted. He's unmuted. Perhaps his mic, maybe your microphone's not. Can you hear me, Landry? Okay. Well, let me text him, see if I can get a hold of him. That's sometimes people have a hard time turning their. You know how you got to turn your camera on sometime. Landry, I don't know if you can hear me. Oh, you can hear me. Okay, great. Now go down to the microphone on your smartphone. There should be. Okay, you're unmuted. Okay, but we can't hear you, Landry. Go ahead, talk. Can you talk? Go ahead, Landry.
Hello?
Yeah, we can hear you better.
Here,
Yeah, we can hear you better.
I'm talking, but I don't know.
All
if
right,
everybody can-
Eureka! It worked. Okay, so let's go back. Let's go back now.
Okay.
And you guys are witness to a miracle.
Okay, let's try then.
Okay, good. This is much better. Okay, which slide do you want to start at?
Okay, so I think we were on the slide 10.
Okay. Okay, we're gonna do this. Wow, we just look at this. We discovered something. Man, oh man, this is science in action. Where you go? Okay. Is that the right screen there? Okay, this is the right one, right?
Yeah, yeah.
Okay, okay. Okay, hope you, yes, yes, we can hear you.
Okay, I think I have already thought about this. This was showing left nostril view when you see on the left the middle cardinal. And I was saying that you can just break the tula equidalis laterally to the middle cardinal to be able to lateralize the middle cardinal away from the midline, away from the septum. This way you can have much more space and a wider exposure. That's what I was thinking about. So let's go to the next slide.
Okay.
Next.
Okay. Yeah, okay.
Okay. So here what I was showing is on the down lower right picture is what I was saying for me is the most important landmark. So some people say go for the middle pivotal, go for the option, and people sometimes struggle to find the option.
Okay.
They don't struggle to find the middle pivotal, but they struggle. Yeah?
Yeah, yeah. Please move your mouth close to the microphone, please.
Too close to the microphone? How
Yeah.
about here?
Yeah, that's better. Better.
Hello?
Yes, that's better.
Hello?
Hello?
Hello, is this better?
Yeah, it's better.
Okay. So what I was saying is, okay, if you go forward to the next slide, what we see is that I will just change my headset just a second.
The sound is the best it's been.
Hello? Anybody
Yes.
hear me? Okay.
Yes, yes.
Okay. Okay, so here on the left pictures is what I was saying that I consider to be the most important landmark is, so on the picture on the left, you are on the right nostril. So when you are on the right nostril, what you see just above the quan is this SER, sphenoethmoidal recess. So the sphenoethmoidal recess is for me what the most important landmark that you should see, because it's easy to find. You just put your endoscope, you go straight down, you see the inferior turbinate, you go straight, you see the posterior rhinopharynx that you see here, quan, CO, and then you will see a bony structure just above the SES, sphenoethmoidal recess. So when you see the sphenoethmoidal recess, just know that if you go straight forward, straight upward, you will definitely find the ostium sphenoidale. Okay. And when you see this sphenoethmoidal recess, you should understand that from the lower margin to 1.5 centimeters upward, you will find the sphenopalatine artery. So the sphenopalatine artery is this artery that bothers
surgeons the most when they do this approach. So you can coagulate there, you can ligate there, or you just can just be aware of it and just avoid putting your blade there. So what we do is when you see this area with the sphenoethmoidal recess, you should know that this is the entrance of the sphenoid sinus. This is the entrance. Half part of the entrance, I would say, half part of the entrance, because the other part of the entrance is on the other side of the nasal septum. So the picture down on the right is a sphenoid ostium that you see, but usually you will not see it wide open like this. You won't see it. You won't see it. So what you see is, as I said, this sphenoidal, this SER, sphenoethmoidal recess. You go upward, you can find it here. So what sometimes is all covered by mucosa. So you just have to use your suction and you just palpate. You palpate softly, you go upward a little bit, 1 centimeter, and you will get there into the ostium. If you don't see the ostium, it's all right. It's all right. I will show you another technique that you can use safely to go. Okay, let's go to the next slide.
Okay. Hold on. Okay.
Okay. So here is just, hello?
Yes.
Here is just a nice picture of what we should have in our mind when we get to the sphenoethmoidal recess. So the sphenoethmoidal recess is like the M that you see here, like the letter M. So you see the rostrum is in the middle. It's always in the middle. So the sphenoethmoidal recess delineate an arc on the left and another arc on the right that makes the M letters. Okay, let's go to the next slide. Okay, so that's what I was showing. When you see, here is a picture on the right nostril. So laterally, what you see, PNA, it will be all covered by the mucosa. So when you see PNA will be the mucosa of the middle turbinate. When you see NS on the right, will be covered by the mucosa of the nasal septum. You see the arc just below is the inferior margin of the sphenoethmoidal recess. And between the inferior margin of the sphenoethmoidal recess and the ostium of the sphenoid that you see SS up, right in the middle, you will see the sphenoid palatal artery that will go there. So just be aware of it because it will be important when you want to do a nasoseptal flap. So let's go to the next slide.
By the way, the sound is great.
Okay, awesome. So another important landmark that you should see before going to your case is what type of sphenoid sinus that you have. So most of the time is a cellular type that you see for 75%. Sometimes you can see the precellular, and very rarely you will see the concave type of sphenoid bone. So what we see usually is a 75% is the cellular compartment, and you should analyze your CT scan. It's very important. You should not rely on MRI when you want to do this approach. MRI is fine, that it will help you to find all the margin of, let's say, pituitary tumor or cranopharyngioma. But in order to get right to where you want to go, you should to understand well your CT scan. Bony structure is very important. Okay, let's go to the next.
I'm sorry. Hold on, I fell off the PowerPoint. Okay, go ahead. I'm sorry.
Next.
Yep.
Okay, so here is just a view that you would get once you get through the sphenoid bone. This is what you should look for. Usually the floor of the cellar is easy to find because it has a particular shape. The prominence of the carotid on either way on either side, I would say either side. So this is what you see. DM is the floor, here is a removes the bone, but this is the floor of the cellar. Below the floor of the cellar is the clivus. So below the cellar, you go straight, you drill your bone, you go to the posterior fossa, anterior approach to the posterior cellar. And then you will see, this is the clivus that you see down here on C. So laterally on either side, CP is a carotid prominence. So this, for us, we don't have the Doppler probe in order to delineate where the carotid are, but what I use usually is that I stay on the midline. And to stay on the midline, you should see on this picture on the left, this is what I'm commenting right now. You see on the back, there is a dark, like a burn area that you see right in the middle. So this is part of the rostrum. Usually when we break out this rostrum to get into the sphenoid sinus, you should leave a little piece of the rostrum. This always shows you the midline, always. You should not rely on the septum that you will see inside the sinus. You should always rely on these small landmark that you see that will show you the midline. So on the right picture is just a nice view when we drill away all the bone that you can see, the sella, the clivus below, the lambus dura on the top. This is the most posterior portion of the planum phenioidale. So this view is very nice. It will help you to understand from below the limit between the anterior fossa. So this is the planum, the middle fossa, this is the sella, and below the sella is the posterior fossa. Okay, let's go to the next slide. Okay, just here is when you drill away all the bone, you will see that behind the clivus, you will see the basilar artery and the pons. Laterally, this is how the ICA go. So here, just another tip is that the ICA will go forward from down to top. It will go straight upward. And then it will make a medial loop first, and then a lateral loop, and then get to the paraclinoid segment. So usually when we have a trauma injury to the ICA, it's usually this medial loop, because this is a part of the ICA which is really close to the pituitary gland. And we really need to be aware of it. The way to avoid it is to stay right in the midline, as I showed you. Next slide. Okay, so I was saying that we need to learn the bony structure, anatomy, and the most important information that you should get from this slide is that inside the sphenoid sinus, you will see a lot of septum inside. So it depends. Some people, they don't have septum inside, but some people can have 2 or 3 or more than that. Rotan made a classification about those septa, but you really need to look into your CT scan to know, because sometimes you don't pay attention to the septum. It will lead you right to the carotid, and you will think that you are opening the cellar floor and you get to ICA injuries. So you really need to understand. You really need to understand this. Okay, let's go to the next slide. Okay, the indications. Indication, what we see here, the most famous indication is pituitary adenoma, followed by craniopharyngioma, but we can have all those indications. Let's go forward. Okay, this is just a case that we did recently in our hospital. Just here to show you that you really need to look in the middle. You see that you have the cellar type of sphenoid sinus. Okay. And you see on the right, you see how it is located, surrounded, and it's really medial. So when it's in the midline, you are pretty sure that you can have it. And inside, you don't see septa there. This is important to see on the coronal view. Okay, let's go for next slide. Next slide. Okay, so let's go to the most practical part of this presentation. People, when they think about an endoscopy, they think about the screen, they think about the telescope. So that's what we see on the right part. At the end, you see screen, you see the telescope, and then you say, okay, I will look at the screen. But you need to be aware of how to connect everything. How to connect everything. So first, we go from the left to go to the right. So first, you need to have a power supply. And then the power supply will connect the camera console to the electricity. This console will be connected to the camera. I will show you a picture of the camera. And the camera is connected to the telescope. The light cable is also connected to the telescope. And so the light cable have a light source that is again connected to the power supply. So you should always know how to mount, because you should not rely always on the technician in the OR. You should understand how it works. So this is a connectivity that you should understand. And for the telescope, you can have 0, 12 degree, 30 degree, 45 degrees, 70 degrees. Everyone has his own advantage and limitation. Okay, let's go forward. Slide. Okay, so this is just a picture on eBay because most of my fellows, they just ask, oh, maybe it's really expensive to get those equipment. I want to do this approach, but I don't have money. You know, when we go to some stores, it's really expensive. You can go on eBay and you find the telescope for less than $300, and it works. Really, it worked nice. All you need to know is that you need to have a 4 millimeter diameters and at least 175 millimeter long. And this is right for you. You can use it to do your cases. So here on eBay, you can find it. Next. Okay, so this is a camera I was talking about. So there are different kinds of cameras. So this is a camera, and the camera is connected to the camera console. So that's it. And the console will be connected to the power supply. So here is a traditional kind of endoscope camera, and these are some new kind of camera that doesn't have wires, but I really trust wires more. And you can find it on eBay for, let's say, $500 or less, $500 US dollars. Okay, let's go again. Go ahead. Yes, next slide. Okay, so for this approach, people will ask again, what kind of instrument I can get? You can again go on eBay for about $650 US dollars. You can go, you just type FES, like functional endoscopic sinus surgery, and you can get those instruments, and this is around the price. So for, let's say on total, for around $2,000, you can have your equipment here and to practice in Africa. Okay, let's go ahead. So now we go to the main instrument that you need to know. So those are the elevators that for me as a masterpiece instrument that you need to have for your approach. So on here, the picture A here is different type of elevator. You use those elevator to dissect away the mucosa. When you get there, I will show you the step, but this is really important that you will use it a lot. If you don't have this, basically you cannot perform the approach. So the punches you see on the right, you will use like 45 degree up or 45 degree down. It will help you to increase your aperture. When you remove the bone of the rostrum, you need those kind of rongeur. Okay, let's go again, next. Okay, so as I said, the elevator the rongeur, and the suction cannula are those that you will use on the nasal stage. On the nasal stage, when you get into the nose, before going to the sphenoid sinus, these are the core instruments that you will use. And here are some dimensions that you can just memorize and buy it. Again, next slide. Next slide. Okay. Again, here you can have those biopsy forceps that you will use to mobilize your nasal septal flap, for example. There are scissors there that you can use to cut your nasal septal flap. I will talk about the nasal septal flap later on this presentation. And on the top here, on the picture C, on the top here is the drill. It's not always necessary. Initially, when you start with microscopic approach, we didn't use this drill. We just had a chisel and a mallet that we used. A chisel and a mallet was fine to open the rostrum. But now you can use a drill. It's much more efficient. Let's go ahead. Next slide. Next slide. I can't see the slide now.
You can't see this. Okay,
Yeah.
you can't see that slide? No? Can you see that slide?
I don't see slide. No.
Okay. No one sees the slide?
I see the slides.
We can see.
Can you see the slide or no?
Yes, we can see.
We can see the, yeah, you can't see the slide, Landry?
Okay, I can see the slide now.
Oh, okay,
Okay,
wow, that's a conundrum. What is that? What does conundrum mean? Well, geez, we can see the slide,
Oh.
but you can't. Okay, how can we?
I see the slide now. Okay.
Okay.
Okay, so as I said, usually the first step is that you will explore the nasal floor, you explore the nasal, and then you will need to incise the mucosa. So on the right are different type of blade that you can use, and I really like using the 12 blade because I can turn it upward, downward, and it's really nice. It's better than the 15 blade. Okay, next. Next. Okay, so once you make your incision, you need those kind of scissors in order to continue making your cut to make the nasal septal flap. Again, next slide. Next. So the cannula is the same, the suction cannula is the same. Next. Okay, so now we are in the sphenoid stage. So when we incise the mucosa, we put it laterally, we are in the sphenoid sinus. Those kind of forceps is what we use to remove the mucosa. It's essential to remove the mucosa, to remove all the septum that you can see inside. Next. And then when you finish removing that, sometimes the mucosa can be really hard to mobilize and to remove. So you can use those RD ring correct to help you get off the mucosa and remove. But mainly this is used for the cellular stage. Once you open the floor of the cellar, once you transect the dura of the cellular floor, you use those RD correct. This is gentle, and so you use it to remove the adenoma, the pituitary adenoma, for example. Okay, next. Okay. Sometimes the adenoma can be fibrous, or sometimes you can deal with craniopharyngioma. So those kind of scissors that is curved to the right, curved to the left, you can use it. And this is, you need to really be used to it because as we mentioned earlier, you have the carotid on both sides. So you really need to understand before making any kind of cut. Okay, but this is really nice when you want to deal with removing craniopharyngioma, for example. Okay, next. Next. Okay, so let's go to the operating room. Usually what we do here is that we start cleaning the nasal fossa using iodine solution. You can use iodine solution or any other kind of antiseptic agent, but usually this is what we use. Iodine, the green one is what we use. We rinse, we clean the nasal fossa several times. We put the antiseptic inside and we suction it on the overhand. We do it for at least 5-10 minutes. Okay, so here again, I want to talk about installing the patient. So in different practice, people make a flexion, like 15-degree flexion of the head. Some people just put the patient lie flat, but all depend on the way you will insert your telescope. But usually what I do is just to put the head 15-degree up, forward, in order to maximize the venous drainage. Okay, next slide. Next slide. Next. Okay. 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 So here is again a view that we used to see. So we make a flexion of the head about 15 degrees, and we turn the head on the right, like the patient is facing his surgeon. And usually we stay on the right side to perform the surgery. Okay, next. Next. Next slide. Okay. So for the ergonomy, usually residents, they just go into the ORs, they want to get the blade, and they don't think about where and when the surgeon is, where the assistant is, where the anesthesiologist will be. So this is really important for ergonomy. So usually this is a setting that we do. Okay, next. Okay, so usually what we prefer to do is to harvest the fat tissue. We harvest it before going to the nasal stage. You get a lot of, usually this is the incision that we use to harvest the tissue. Next. We harvest fat tissue usually for the closure of pituitary adenoma cases. And in some instances, when we deal with craniopharyngioma, what we do is we prefer to harvest on the thigh, because here you can have both the fascia lata and you can have fat tissue. So you don't perform two incisions, you have both there. So this is just the marking incision of where we use to get to the fascia lata. Before getting there, we have fat tissue, so we harvest it and we go forward. Again, next slide. This is just a picture of the fascia lata that we harvest. This was the case of craniopharyngioma that we were performing. Again, next. Okay, as I said again, we need to really understand how the middle turbinate and inferior turbinate are located, and this narrow corridor between the nasal fossa and the turbinate, you need to expand it. You really need to expand it out and be more comfortable introducing your sanction, introducing your telescope, and again, another instrument. So on a regular practice, what we do is binostril approach. Some people just prefer mononostril, but we don't really see any significant difference. But it increases your comfort when you do binostril approach. Okay, again. Okay, okay. So here is you see two different ways of putting your endoscope, your telescope. Either you go downward or even you go 45 degrees. So usually on the right is how people introduce the endoscope. But this way is really depending on the way you install your patient. If you install your patient 15-degree 15-degree flexion, this is on the right, how you introduce your telescope. But usually when your patient is flat on the table, this is on the left, how you will introduce your endoscope. So my tip for people to use this approach is when you get through the nose, go down first. Because when you go down, you see the nasal floor, you see the inferior turbinate, you will see the sphenoethmoidal recess always. And it's really difficult for you to go down and get to the brainstem. It's really difficult because you will have to drill all the bone, but it's really easy to misplace your endoscope and go straight to the ethmoid bone, to the anterior fossa. This is one of the common mistakes. So you go down first. It's easy, it's safe. You see the sphenoethmoidal recess, and then you can go upward. Okay, next slide. So xylocaine nasozoline, this is what we have in our operating room. This is what we use. We soak the patty in it, and we put right between the nasal septum and the middle turbinate. We put it there again, and again. We can put 3 patty there as much as possible, and we wait. We wait for 5 minutes. We take our time. We make joke, and then after 5 minutes, we remove our patty, and we will see that it increase. So the picture on the right is where it's how we put our patty. We put our patty there between the nasal septum and middle turbinate, and we wait for 5 minutes. And it's magic. You can just have a better expanded view, and you can go forward with your instrument. Okay, next. Next. So at this stage, on the nasal stage, is when, if you want, depending on what kind of procedure that you do, you can, at this stage, harvest your nasal septal flap. This is a sagittal view on the left, and this is a endoscopic view that you have on your right. So on your right, we are in right nostril. Okay. So the nasal septal cut is as shown here. You make a cut from backward to forward, from posterior to anterior, and then you go down. And for down, you go again backward. So you will have the flap that is vascularized by the sphenopalatine artery. That way is safe. So you take this flap, you move it, you mobilize it down into the posterior rhinopharynx, and then you can continue your procedure. Next. Next. Okay, so this is an example, picture A. So picture A, if you can zoom in, you see that we have the sphenoethmoidal recess that you see RO, the sphenoethmoidal recess. So here is a left nostril, left. Picture A is a left nostril. So when you get there, you see the lower margin of the sphenoethmoidal recess. This is where you make your cut. You make your cut there from backward to forward, from posterior to anterior. So you make your cut, you go down and you go anteriorly. And the picture B is the same thing. You move anteriorly with your knife, and then after that you go upward. You go upward on the picture C, you go upward on the nasal septum, and then after you go backward and you make this. Okay, next slide. Okay, next slide. This one was just to show you the view that you have when you wait for 5 minutes. You leave your patty there for 5 minutes, and then you have this view. Okay. Forward, next. Next slide, please.
John?
John? Hello? John? Next slide, please.
Next slide, John.
Okay. So here, the picture on the top left, it's a right nostril. Right nostril. All those pictures are right nostril. So when you are on the right nostril, see the distance between the lower margin of the sphenoethmoidal recess. You see the lower margin where you see the letter CO. So from CO to SO, the sphenoidal ostium, there you have this in your mind that the sphenopalatine artery will have this vein coming in the middle to go to the nasal septum. So this is a picture you see in the middle, okay? You have the mucosa, but bear in mind that the sphenopalatine artery are going inside the mucosa. So this is the message I want to show here. Next. Next, okay, those are, again, the same view, inferior turbinate. As I said, when you put your endoscope, you go down, don't hurry to go up, go down. You go down, you see the inferior turbinate, you see the middle turbinate. You go forward, you will see the picture B. So from A, you go to the picture B. By moving forward your endoscope, down along the floor, you will go straight to the posterior rhinopharynx. You will see the arc that makes the lower margin of the sphenoethmoidal recess. And from there, you go upward, you will see the middle turbinate. You go upward. If you want to find the ostium, you get there. You go upward for about 2 centimeters. You put your suction, you just palpate with your suction, and then you will get into the hole that is the ostium. Again, next. Next. No, okay. So once you are here, look at the picture C. So the picture C here just show you how you make your incision. So you're free if you want to make the nasal septal flap, you do as I described previously. Or you can just make a vertical incision down, up to down, and then you will move laterally the mucosa. If you do this, you do it posteriorly. And then when you finish to mobilize laterally, it will show you the ostium. And from your ipsilateral ostium, you just move a little bit laterally for about 1 centimeter, you will get to the left ostium. From there, you do your posterior septectomy. And then you're inside the sphenoid sinus. Okay, next. Okay. So again, this is a picture showing you that, so as you see the mucosal flap, the picture on the left is a mucosal flap, and then you will see the cartilage, the septal cartilage, and then with your elevator, you go to the left nostril. Simple. So you do this and you see the picture that you see you have on the B, on the right. People look like, people describe it here like the rostrum of like a ship boat, or some people describe like what kind of animal, they call it the hull. Okay, so it's like 2 eyes. The ostium are like 2 eyes, and the middle are like another nose, kind of. Okay, so you have this view, you're all right, and you can go forward. So what I want to show you again, another tip that I learned from my mistakes is that the picture on B grossly is like a diamond shape. A diamond shape where you can divide this diamond on an upper triangle and a lower triangle. Unfortunately, I didn't put a horizontal line to delineate those upper triangle and lower triangle. So when you have this view with the 2 ostium, again, it's like a diamond shape. So the inferior margin of the inferior triangle is a lower margin of the sphenoethmoidal recess. This is an inferior margin. And on the upper triangle, you will see both ostium, and you go on the top. So when you are in the middle of this diamond, you can move laterally as far, displace the mucosa as far as you can to expand your corridor. But if you see this diamond shape and you see that you're going on the upper triangle, so on the upper triangle, you cannot displace your mucosa laterally. You cannot, because you're going to the ethmoid bone. So if you have this diamond shape, go straight, stay in the middle of these diamond shape. Don't go upward. You go upward there, you will make your drilling. You get into the plantar sphenoidale, or you get into the ethmoid bone. You have a CSF leaks, and if you want to go to the cellar, don't go up. Stay in the middle. Use your horizontal line that join both ostium. Use it as your superior landmark. Don't go above it. You go above it, you get into the ethmoid bone, you get into the anterior fossa, you get CSF leak. Okay, so next slide. Next slide. Next.
Not this one?
Yeah, go next. I already talked about, okay. So this is the view that you have. So on picture A here, you can use the drill as I show you among the instrument list, or you can use your rongeur or your forceps and you cut this. As I show you again on the picture B, you will see inside. So when you use this technique on the picture A, just leave a little piece of bone that will remind you the midline. You keep a little bit of bone. And if you look on the picture C, down, you will see the letter I, W, S, P, H, S. So here is a little piece of bone that shows a midline. Don't look for the septum that you see into the sphenoid sinus. Don't look at that because it's not the midline. The midline is what you see down there on picture C. This is a midline. This is what you should consider. It cannot fail you. Okay, so you get into your sphenoid sinus. You try to recognize and identify the cellar, to identify the optic proeminence, the plantar sphenoidale, both carotid proeminence, and then remember the piece of the rostrum that you leave will show you the midline. So this is the approach to get into the transsphenoidal route. From there, you can go to the clivus, you can go to the cellar, you can go to the anterior fossa. Okay, next slide. Next slide. Okay, so this is the real field view. You have sometimes a lot of bleeding. So on picture A, as I show you here, you have both, because here they did a posterior septectomy that allow you to see both middle turbinate. So here, because they remove the posterior part of the nasal septum, you can see both middle turbinate. And you saw in the midline, you see straightforward, you see the rostrum, that you see the kill. So this will show you the midline. So even if you go just above, you drill off, just keep a little piece of bone here, it shows you the midline. Okay, next. Again, this is what I'm insisting, highlighting again on the picture on the right, is this little shell of bone that you should keep to don't go too laterally. Again, next slide. Okay, so when you are inside the mucosa, when you're inside the sphenoid sinus, don't forget, remove the mucosa. You remove the mucosa so you won't come back for mucosal surgery. You remove every mucosa that you see there. Again, next slide. Okay, so we're going to the hand. So what I want to show you here is the advantage and the limitation. So usually people, they use a 0-degree endoscope. So it gives you a nice view above and below the scope. And if you want to do like craniopharyngioma surgery, or when you have a suprasellar component of pituitary adenoma, it's better to use an angle endoscope, like a 30-degree to 45-degree, sometimes to 70-degree. And so you rotate the endoscope. You rotate the endoscope, it helps you to have this panoramic view, depending on what you need, what kind of procedure you do. So usually, basically for pituitary adenoma, 0-degree is enough for you to get there. But when you do craniopharyngioma, you need to drill a little bit the tubercle cellar. So you need to have an angle endoscope to be able to see the optic chiasma and see above. Yeah, so this is the nuances that you have. But for me, sometimes I'm comfortable using a 30-degree endoscope because it allows me, when I get into the nose, to sit down, I like to sit downward, to see the floor. And then from there, I'm pretty sure that I will not go too high. Okay, next. Again, those are different type of harvesting. So you can do like a small, like A, or an extended nasoseptal flap. And all these will help you to make the closure really easy to do. Okay, and usually that's what I do when I do craniopharyngioma. Okay, next. Okay, I think this is a video. I don't know. Can you play it?
Yeah, we can try it. Why not? Okay.
Yeah, let's try.
Okay, let's try it.
Let's go for.
You can't hear that, right?
Yeah.
Do you need the audio, or can you?
No, I don't need the audio.
Okay.
I don't need the audio.
Okay.
Oh, okay. So okay. Oh, that was a case. I tried to make a video from my own case, but I think my computer is too slow for that. But just this is a case that you can see on YouTube. Can you go forward on the video?
Okay.
No, forward. Yeah.
Where do you want to go?
Okay. Yeah, okay. So here they show you how to out fractures the middle turbinate. So here is a right nostril view. So on the left is the middle turbinate, on the right is the nasoseptum. So they expanded the corridor here by using the patty. And so they go straight. This is a superior turbinate. Oh, no. Okay, just skip this video. Let's go forward.
Okay, you want to stop the video?
Yeah, let's go forward.
Okay.
I think we are close to the end.
Do you want me to go close to the end, or?
No, this slide and we go, okay. So yeah, so here I just want to show you a picture just to mention that we can use this approach to go for craniopharyngioma, to go for extended approach to those supracellular lesion. Okay, next. Okay. So again, when you want to do, for example, extended approach, you need to consider this angle, the angle made by the pituitary stalk and the optic chiasm. So when this angle, I'm describing the picture on the left. So this angle, when this angle is too narrow, it's really hard to use this approach to get to do surgery for craniopharyngioma. It's better to do transcranial approach. That's my point of view. But when this angle is wide enough, that means you have space between the optic chiasm and the pituitary gland. So this space is what you use to get to the craniopharyngioma, for example. So this is a picture of a dissection I did years ago to show you this angle that I'm showing on the right. This angle on the top, you'll see the optic chiasma and the two optic nerves. Below, you see the pituitary stalk, and below the pituitary stalk is the pituitary gland. So this is this corridor that we use when we do craniopharyngioma. So on the MRI, you can see whether this angle is too narrow or if this is wide enough, because this is where you will put your suction, all your instruments, suction, scissors, endoscope. Okay, next. Next.
Okay, hold on,
picture.
I got it.
Okay, so again, this is an overview to help you understand where is the sella. Above the sella, you have the intercavernous sinus in blue. So let's focus on the picture on the right. So the intercavernous sinus, sometimes it bleeds a lot. So what I do and what my suggestion is to coagulate it before making this transecting it. So you can make a cut above and a cut below, and you use your bipolar to coagulate the sinus in the middle before transecting it. And when you transect this, it gives you this view that I showed when you have on top the optic chiasm, below you have the pituitary gland, and right there you have the pituitary stalk, and you can go either way of the pituitary stalk to remove the craniopharyngioma. Okay, next slide. Next slide. Okay, so this is a view of a dissection that I did years ago, where you can see that when you drill below the pituitary gland, you would go straight to the pons and the basilar artery. You see there, you can see the third nerve. When you drill above the pituitary gland, you will get into the optic chiasm. Above the optic chiasm, you have the anterior communicating artery. So virtually, you can do aneurysm surgery for ACOM aneurysm through the endoscopic endonasal approach. But really, I don't think it's useful to do it. But this is a panoramic view that you can see on both sides. You have the ICA. Okay, so next slide. Okay, so for the closure, what we do here, we don't usually have fibrin glue. So we use facial latta, fat, Surgicel, and we use these urinary catheter that we use. We inflate the distal portion to make it stick together. Usually this is enough. So this is on the right, the view that you have when you mobilize your nasoseptal flap to put, to make the closure of the sellar floor. Okay, next slide. Okay, so yeah, so the complication you can have, ICA injuries, if you go too laterally, if you don't look at the small piece of rostrum that you left, you can have CSF leaks, depending whether you get through the ethmoid bone or you were doing your pituitary adenoma surgery and you open the diaphragm, you can have CSF leaks. You can have posterior epistaxis. This is because you injure the sphenopalatine arteries. And if you go too high, you can have anosmia by destroying the fiber of the olfactive nerve. On long term, you can have cynosure, you can have mucocell, or you can have chronic sinusitis. Okay. So the last slide, conclusion. I hope I didn't talk too much, but this is a beautiful approach. I really like it to do craniopharyngioma surgery or pituitary adenoma surgery. I think that a younger neurosurgeon, that's my point of view, but I think that younger neurosurgeon would be very, very comfortable using this approach because a lot of us, we used to have video games home. So we are comfortable using our hand and looking at the TV. So I bet that this approach will be more and more used by young neurosurgeons. Okay, so thank you.
Oh, excellent. And I really appreciate your persistence. And we're able to get that. I mean, from the 7th slide on, which we're going to edit, by the way, the sound was excellent. And I'm glad we persisted because that seems to me, I'm not a neurosurgeon, but it seems to be a topic that a lot of residents want to see, a lot of students want to see, and perhaps Naru can make a comment on that. Go ahead, Naru, you got to unmute there. You're muted there. See, we're all getting to learn this platform, but we'll get better. Go ahead, Naru, you're muted. I don't know why we're having trouble with the mute button today.
Do you hear me?
Yes, we can.
Okay, thank you very much, Dr. Landry. It was a very nice presentation. I done a lot of revision about surgical anatomy about this transphenodal approach. And I don't have anything to say, just thank you. Thank you very much to share with us your knowledge. Thank you very much.
Okay, more comments, questions? I'm not gonna ask you, Aminata. I'm not gonna say a word.
Thank you for persevering. We really enjoyed the presentation. It was very informative. The images were fabulous. And once you got on the cell phone, the sound was perfect. Thank you again.
Yeah.
I think next time we'll use it.
But no, we're going to go back and re-edit that, and we're going to redo the first part, Landry, okay?
Okay.
So later, after. Okay. Let's see, more comments, questions from anybody? Or just to say hi to Dr. Landry?
Yeah, John, I just
Go ahead, Natalie.
I just want to say thank you to Dr. Landry for the presentation. We look forward that you should present in our sessions next time. I also wanted to say that Dr. Landry is our mentor and my teacher in Ivory Coast. So he's a very good mentor, very attentionate. He even helps me present some of my cases that I presented earlier. I also wanted again to thank him for being a member now, or a coach or a mentor of AFANSU on behalf of Eric and myself and other members. But I have a question, just a little question. Sure. You said the sphenopalatine artery is one of the arteries that disturbs you a lot during surgery, during the nasal approach. So I just wanted to ask, if it is injured, is there a major consequence, or we can just pass over it?
Well, they're not major consequence. For example, if you want to do a nasal septal flap and you injure the sphenopalatine artery, there is a main trunk and there are branches. So when it's just branches, it's okay. But if it's the main trunk, I mean, you will have an ischemia of your flap. This is what you should look for. But usually you can ligate it when it's bleeding. And this is usually what ENTs do when they have like huge epistaxis. They go inside, they locate, the main trunk is just lateral to the attachment of the middle turbinate. So you go there and you can coagulate the sphenopalatine artery without any consequences.
Oh, okay.
Because I told you, you have the anterior ethmoidal artery, posterior ethmoidal artery that gives blood supply to the nasal septum.
Mm-hmm. Okay, thank you, doctor. Then I have a question, another question. It was just an imagination. Has there ever been a case of brain herniation through the hole that has been done at the sphenoidal recess?
No. If you're doing cellular approach, is what you can have, because if you remove a pituitary adenoma, for example, what you can have is you have just on the top, you have the optic chiasm. So optic chiasm can fall, can go down, and you can have some visual disturbance. This is something you can have. So usually what we do is when we remove the adenoma, We take the fat tissue that I show you how to harvest. So you take the fat tissue and you put a little bit. Don't put too much because you will make another tumor there. Put just a little bit to avoid this fall down of the optic chiasm inside. But you should know that on the top of the pituitary gland, you have the pituitary stalk. And the pituitary stalk is surrounded by the diaphragm cell.
Okay.
So in order to have a brain herniation, it's really difficult. It's usually the optic chiasm that can fall down.
Okay, then on one of your last slide, you said sometimes you may coagulate the cavernous sinus.
Intercavernous sinus.
Yes. Is there no risk? Is there no utility of that part that may endanger or give other complications?
No, there's no risk. You know, on either side of the pituitary gland, you have the cavernous sinus. Okay, but there is a venous circulation surrounding anteriorly and posteriorly the pituitary gland. So it just connects both cavernous sinus. This intercavernous sinus just connect both cavernous sinus. So you can just coagulate. It will not have any injuries. But if you don't coagulate, for example, you don't coagulate, you can have a lot of bleeding. And I remember one of my very first case that I was observing as a resident, the patient actually he died. There were a lot of bleeding and we were not able to coagulate on time. And unfortunately, the patient he died. So what I suggest is to coagulate before transecting. So you make a cut above, you make a cut below, and you coagulate with your bipolar. And even if you coagulate, you transect and it's still bleeding, you can use your bipolar and coagulate it. There's no risk.
Okay. Once more, thank you, Dr. Landry, for persevering. It was really interesting, as we said last time. Very interesting.
It was frustrating if I had to postpone again. So
no,
I'm happy that I could work today.
Okay, very good. Any more comments, questions from the panelists? This is your chance to not only meet Dr. Landry, but to meet the rest of the panel. It's okay with time.
Okay, Dr. Bennett.
Okay, anything to say, or you just want to say goodbye, Dr. Kabulo?
No, I have a small question.
Oh yeah, go ahead. We have plenty of time.
Thank you, Dr. Landry, for that brilliant presentation. I really enjoyed your presentation. So I have two questions. The first one, what are the contraindications of that approach? When do you not do that approach? And the second one is, do you also sometimes do the combined one? You do open craniotomy and combine to the endoscopic transsphenoidal. Thank you.
Okay, thank you. So obviously, if you ask me what are the contraindications, I would say usually indication first are tumor that are in the midline. Okay, usually we use this approach, as I said, for the anterior fossa like tuberculum meningioma, for example, or you can use it for a pituitary adenoma, chorinopharyngioma. But when you should not do it is when the lesion go beyond the midline. If it goes to let's say too laterally, too upward, it's not a real contraindication, but it's just that you will not be able to remove all the tumors. You will be able to remove tumors that are in the midlines, but extending the midline, you will not be able to do it. So usually when you have those cases, you do two stages. You do the first stage endonasal, and then after you do transcranial to remove. I don't know if I answer your question, but sometimes you can open the cellar and you find that the tumor is really fibrous. So when it's really fibrous, you you have the choice to make some cut with the scissors. That's something I don't do because I'm very afraid of the ICA. So usually when it's really fibrous, I cannot remove it. What I do is I close the case and I do again to the transcranial approach.
Okay, very good. Other comments, questions from the panel?
I may agree with what you say, Dr. Landry. Of course, if you have cases, like example, also when you don't have good sinus and you know that it will be difficult to make perfectly your approach, it is not what you should do up approach. And also, I don't know, Dr. Landry, if you have experience about the paraseptal approach in the cases of meningioma, clinoid meningioma or chordoma, if you have cases if you perform paraseptal approach.
Well, I don't do that. So far, I don't do that. I'm very comfortable with midline lesions.
Midline,
okay. Because, you know, in our context, you don't have fibrin glue, you just have Sugicel, you see. So when you go laterally, you have the cavernous sinus, you can encounter bleeding, you don't have hemostatic agent. So for now, I don't do that. When I will have fibrin glue in commonly basis available in the country, then I will start doing those kind of cases. For chordomas, it's really rare. I didn't have the opportunity to do those. So for paraclinoid meningioma, I think that meningioma intracranial lesion, so I prefer to approach it intracranially.
Intracranial. Okay, thank you.
Yeah, welcome.
And nice also to meet you. It is the first time I see you. I don't know, maybe I meet you for Congress or something like that, but nice to meet you, and I really enjoy your presentation. It is master's class. Thank you very much.
Thank you. I saw some of your presentation before. I'm really impressed by the way you're willing to give more of what you learn. And usually, if you are able to explain something, that means you understand. So yeah, I'm very impressed by you, and I wish you the best for your career.
Thank you very much.
By the way, we have an anatomy lab here in Abidjan, so you are very welcome to come anytime after the COVID-19.
Yes.
You can come and we will have a fun time dissecting and learning neuroanatomy in our anatomy lab. Yeah.
Thank you.
Nice. Hey, John, I just wanted to present another of our mentors and teachers, Professor Esperance. She's just, I don't know if she can present herself. Professor, please can you present yourself. The only female professor in Abidjan. So
it is our professor of
yeah, Professor Boale. She's our mentor.
She's our mentor. Welcome, Professor Boale. Okay.
Okay. Go ahead. Go ahead. Hello.
Hello. I want to congratulate Dr. Landry for his nice presentation.
Thank you.
My English is not so good, but I want to congratulate him and tell him that it was a very good, a very nice presentation. Thank you for your conference. It was very good.
Thank
you, Professor.
Thank you. Thank you.
Thank you.
My English not so good. Eh?
No, we're going to have these in French. We're going to have them. Yeah, we're going to have them in French too.
Thank you, Dr. Kuna. Thank you, everybody, for this
video conference.
Well, you know, Landry, we can do these in French also. We can do presentations in French. If any of you want to in the future, Naru, if you want to do them in French, okay, no problem. We'll do them
No
in
problem,
French.
no problem.
We'll do them in French. We'll do them in French.
That also.
Okay.
Thank you very much.
Okay. Okay. We're gonna end this, and we'll end this, and I'm gonna actually edit the video so that we fix the first part of it. You know, the first part was a horror show.
Oh yeah.
Yeah, Landry, do you want to? Let's go back and do the first like 6 minutes, okay? We can
Yeah.
redo. We can redo
John.
it. Yeah.
John, please, there's a question from Kennedy to Dr. Landry.
Okay.
He's asking if Dr. Landry has ever gone for a tuberculum cell meningioma with this approach.
Well, for now, I didn't perform this approach. It's mainly due to the lack of instrument. As I said, you need to have let's say nice scissors to be able to dissect the tumor. You need to have a hemostatic agent. You need to have material for the closure. For me, if you remove the bony structure of the anterior fossa, you need to have some kind of bony-like material to close it. You know, but on a regular basis, we don't have it. That's why I don't try it. Maybe when I will have a kind of gasket closure or kind of implant that like mesh implant, but I don't have material for the closure. This is why I didn't try it yet.
Okay. Okay, he has a second question. He said, in view of it being fibrous and a risk of tagging, he had a
the risk of what?
In view of it being fibrous or risk of tagging, why not use the approach? Oh, okay. He said he answered that already. Okay, it's okay. I think this question is ended. Thank you.
Okay, yeah, I'm just putting this together now. Okay. Okay, yeah, we'll just all you guys, we're off the air actually now. I'm going to stop recording this right now, and Landry, what I'll do is just start. I'll get the PowerPoint. And we'll start at the beginning, and I kind of have a feeling of when we really start screwing up. Which, you know, so we'll just go, and I'll just let you know is, okay, let's stop, okay?
Okay.
Okay, so just stay here. Let me get this PowerPoint. And actually, I'll just start from the very beginning. Okay, wait a minute. Why is not fully screen? Okay, hold on, I'm giving. Okay, very good. Let me get. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good day, it's Dr. John Bennett broadcasting from Miami Beach for the home of Neurosurgical TV. We have the pleasure of having Dr. Landry here today to give a presentation, and this is actually a redo, but we're going to try to make it work because we finally figured out the sound. So anyways, thank you, Landry. Could you please introduce yourself and just let me know when you want to start the PowerPoint.
Okay. So I'm Landry Cannon. I'm working as a consultant assistant professor at the University Félix Houphouët-Boigny in Abidjan, when I have a joint appointment at the Laboratory of Human Anatomy and at the Department of Neurosurgery. I got a master's degree in US 2018 in human anatomy.
Okay, you want me to start the PowerPoint?
Yeah, let's do it.
Okay. Let's see. Let me get to you imagine you want to start the beginning here.
I think the first 9 slides are good.
Okay. Okay. Can you see it okay?
Yeah.
Okay.
Can see.
You can begin.
Okay. So let's go to the next slide. As an introduction, this is the transphenylated approach is is a very hard approach. So one of my masters just remind me that Egyptians used to dig a hole through the nose to suction the brain in order to make the involvement. So a long time ago, people knew that you can get through the brain through the nose. So later on, we developed microscopic transphrenic approach. And this is something that we learned decades ago. And now people are using more and more the telescope, the endoscope. And these endoscopes are the advantage to give a panoramic view while you're doing your cases. So the interest of this approach is that ENTs and skull-based neurosurgeons both perform this approach. And there are many centers where they both do in the OR, like the ENT does the nasal phase, and the neurosurgeon, they get in to do the sphenoid stage and onto to the skull base. So these endonasal transphrenic approach give you a wide range of view of all the three step of the skull base. It gives you an anterior view of the anterior skull base, middle skull base, and posterior skull base. So this is a hub where you can move your endoscope to reach those all kinds of lesions, especially in the midline. Next slide. Next slide. Okay, so we will go to the anatomy and next to the indication, and we will take much more time to the surgical technique. Next. Okay, next slide, please. Okay, so this is a sagittal view of what we are going to talk about. You will introduce your endoscope. So the endoscopic is not endoscopic approach. This is just the endoscope just move your eyes deep inside the view, inside the field. So this is what we're going to talk about. Okay, next slide. Okay, so if you want to get comfortable with this approach, you need to know at least the bony structures, and then the mucosa, and then how the blood get into the mucosa. So on the upper left is the sagittal view on the midline. Different color are used to highlight different kind of bone that you will see. At the cancellous, cartilaginous bone in orange, the ethmoid bone in green, and in red is the vomer bone. Those are what you will encounter during your approach through the nasal septum. If you go forward, posteriorly, you will see the sphenoid bone, and mainly you will see the sphenoid sinus that then you will get there to get to the anterior fossa, the plantar sphenoidalis, the sella, or the clivus. Down along the floor of the nasal fossa, you will see the mandible bone. So if you go laterally, this is a picture that we see on the right. If you go laterally on the sagittal plane, you find those three turbinates that are really famous. The inferior turbinate is right and readily, you can see readily when you introduce your endoscope. The inferior turbinate, and then up you will find the middle turbinate, and up again is the superior or supreme turbinate. We don't talk much about this supreme turbinate. Okay, so let's move forward. So you need to know the bone, but you need to know that when you do this approach, the mucosa will bleed. The mucosa bleed a lot, so you need to know where the blood comes from. It comes from three main sources. The three main arterial supply are on the top, the ophthalmic artery, anterior and posterior ophthalmic artery, and on the posterior lateral side, you will find the sphenopalatine artery. So the sphenopalatine artery comes from the posterior side, and we give a branch into the septum, nasal septum, and give another branch to the lateral wall of the nasal fossa. That we will show deep in the next slide. Okay, next. Okay. So the anatomy on the frontal side, you can see on this cut, you have in the middle the septum. You have in TI is inferior turbinate, laterally inferior turbinate. Upward, you have the middle turbinate, and you have more laterally the bulla ethmoidalis. That is really not, you really not have to worry about when you're doing your midline approach. On the right picture is what you see is ethmoid bulla, and you see the relationship between the middle turbinate and the sinus, the maxillary sinus. So the ENTs, they use this approach to get to the maxillary sinus too. But for us, what you really need to understand is how we have the disposition of the inferior turbinate, middle turbinate. And laterally, the ethmoid bulla is something that you can just crush to make more room to displace laterally the middle turbinate without any consequences. Okay, let's go forward. So that was a short video to help you identify the inferior turbinate, middle turbinate, bulla ethmoidalis. So if you should, okay, so the video is playing now. So this is a short video that we did in our anatomy lab. So when you get your endoscope, go down, you'll find the floor. You find the floor laterally. So here is the left nostril. So you see the middle turbinate. On the left, you see the nasal septum. If you go forward and upward, you will see the middle turbinate, and laterally, you have the bulla ethmoidalis. Lateral. You can crush this bone with your rongeur, and it will help you make more space to mobilize laterally the middle turbinate. Okay. So if you put laterally your middle turbinate, you have this corridor. This is an important corridor. This is where you put your instrument to get to the sphenoid bone and the sphenoid sinus. Okay, next slide, please. So this is again to show you the relationship between the middle turbinate and the bulla ethmoidalis. It's just lateral to the middle turbinate. That's just what I want to show you here. So on the next two right picture, you see how we can use a forceps to just crush down the bulla ethmoidalis. It will give you more space to move laterally the middle turbinate. Next slide. So once you introduce your endoscope, you have this view that we see on the left. The view is the nasal septum and the inferior turbinate. So this is the right nostril. You have medially the nasal septum and laterally the inferior turbinate. And you move along the floor, you move your endoscope along the floor, you will find the picture on the right. Is that when you go along with your endoscope, you will find the posterior rhinopharynx that you see here on CO. And then upward, you find the middle turbinate. So for me, the CO that you see here, you will see the CO have the shape of an arc. So this arc is the lower margin of the sphenoethmoidal recess. And for me, this is the main landmark. Easy to find, and this will give you the entrance to the sphenoid sinus. Let's move forward. Slide. Okay. So this is the same view in more detail, in more magnified view. The inferior turbinate laterally, the middle turbinate upward. So you have medially to the middle turbinate is the sphenoethmoidal recess. So the sphenoethmoidal recess, you should bear in mind that this is the entrance of your sphenoid sinus. If you remove the mucosa, if you remove you drill off the bone, you get into the sphenoid sinus straight. Okay. So the picture on the right, again, this is the right nostril. you see the inferior margin in the shape of an arc, and above it is a sphenoethmoidal recess. You cannot miss it. You just move your endoscope forward, deep down you will find it. Okay, next slide. Again, this is the relationship. People, when they do this approach, they are looking for the ostium of the sphenoid sinus. So if you see the lower margin, now I'm commenting the picture on the left. So you have CO here is the arch, the lower margin of the sphenoethmoidal recess. You see the lower margin, you go about 1.5 centimeter upward, you will find your ostium there. So if you find your ostium there, this sphenoethmoidal recess is again what you will find, is where you will find the sphenopalatine artery. So if you find the ostium upward, you can go there, you just widen the aperture, it will help you to get through the sphenoid bone. But if you are from this ostium and you go like 1 centimeter below, you'll find the sphenopalatine artery and it will start bleeding. So usually I don't make any incision there. I will make my incision on the nasal septum and move laterally the mucosa to reflect a pedicle flap with the sphenopalatine artery inside. So the picture on the right, again, we show you this sphenoid ostium here. So you see the relationship with the sphenoethmoidal recess and the sphenoid ostium upward. Sometimes the sphenoid ostium is just recovered by the mucosa. So just you use your section and you palpate smoothly, and then you will get, when you go upward, you will get through this ostium easily. Okay, next slide. Okay, this is a coronal view that helps you to understand the arc that I'll show you. Both arc will make a kind of M letters. So when you see those arc, the sphenoethmoidal recess, lower margin, you should understand that just after that, you will get into the sphenoid sinus. And when you get into the sphenoid sinus, you should understand that laterally are the ICA, the cavernous sinus, V1, V2, and all those nerves that you will find laterally. But this is not, this is just something that you have to bear in your mind. Okay, so next. Okay, here again, I want to show you the trajectory of the sphenopalatine artery. So here again, this is the right nostril. So you see in red that the sphenopalatine artery are located between the inferior margin of the sphenoethmoidal recess and the ostium upward. So in the middle, at mid-distance between them, you will have the sphenopalatine artery running within the mucosa. It will give up branches that will supply the nasal septum. Okay, next slide. So you should also understand that the pneumatization of the sphenoid bone is different and can vary from patient to patient. So usually what we find is in 75%, we have what we call the cellular type of the mucosa. And in 24%, you'll find a pre-cellular sinus. And in just 1%, it's really not pneumatized. It's just what we call the conchal bone, the conchal sphenoid bone. It's not well pneumatized. Okay, next slide. Okay, so when you get inside the sphenoid sinus, you should look for those landmarks. So the CP, so the first landmark that you should see is the floor of the cellar. Here the floor is removed, and you see DM here just means dura mater. so the dura. So when you see this cellar floor, below the cellar floor is a clivus. Above the cellar floor, in the midline is this planum sphenoidale. Laterally to the planum sphenoidale, you have the optic proeminence. And laterally to the cellar, you have the carotid proeminence. Between the carotid proeminence and the optic proeminence, you have what you call the optocarotid fossa of the optocarotid recess that you see, OCR. Opto for the optic nerve and carotid, optocarotid recess. So you should always look for this. And as I mentioned earlier, if you get this view, you should look for the rostrum again. So you remove, you move your endoscope a little bit backward in order to find the rostrum, because the rostrum is what will show you the midline. Don't trust the intrasphenoid septum, because it's not gonna show you the midline. Look for the rostrum. So you should leave a little piece of bone on the rostrum. That will always show you where is the midline. If you stay on the midline, you will not injure the ICA. So this is the main message on this slide. Next. Okay. So again, on the left, you see that you have the on PG is the pituitary gland. So that shows you the relationship between the pituitary gland and the ICA and the clivus. So ICA, first, when you get to the sphenoid bone, it will run upwards, make a medial loop, and then go forward to make a lateral loop, and go backward again to get to the paraclinoid ICA. So usually the most vulnerable part of the ICA during this approach is the medial loop that you see. Yes, the medial loop is the closest part of the ICA to the pituitary gland. And when you see the picture on the right, just to show you that if you drill, when you continue drilling below the pituitary gland, you drill the clivus, you remove the dura, you get right in front of the basilar artery. Virtually, this is something that you can do if you want to get to an aneurysm that is located at the basilar tip, but it's not comfortable to do that. Okay, just to show you, if you go forward, this is where you go. But again, when I put my endoscope, I don't look, I go down first, because if you go down first and you get into the sphenoid sinus, you will have a bunch of bone to drill before getting to the basilar artery. So it gives you much more time to realize that you are going wrong. But if you go upward, too upward, and you miss the pituitary gland and you drill a little bit, the shin shell that makes the planum sphenoidale, you will make an incision there and bam, you have CSF leaks. This is too upward. So it's better to go downward and identify upward the pituitary gland. Okay, next. Okay. So the CT scan for each patient is valuable. You should look for the septum that you find inside the sinus, because this will delineate compartment. If you don't analyze well, you may get into a small compartment and you think that you are inside the wall sinus. And if you think that you're inside the wall sinus, you will get, usually you go laterally, and this is how you can injure ICA and have a bleeding, usually bleeding, sometimes can be fatal. Usually here in Africa when you don't have interventional procedure. So you should look and study carefully the septum inside. And then if you go in the midline, like making a nasoseptal flap, you get in the midline and you can easily manage those septum and avoid to go too laterally. Next.
Okay, Landry, I think we've got plenty. Okay.
Okay.
Yeah,
cool.
you know, we're gonna put the two ends together, and we have dynamite sound, the whole thing.
Okay. Thank you.
You wouldn't believe the first part, man. Oh, it was horrible. You know, we couldn't understand it. You know, with the first time, but this time was excellent. So, okay, we'll get that together and get it to you as soon as I can. But thank you very much. Thank you very much. Okay. Okay, guys. See ya.
Bye-bye.
All right. Well, I'll stay here. Well, a lot of people are still here. Wow. Hey, did you see Yuha last night?
No.
Naru, you didn't see Yuha last night?
Yes.
Yuha.
Yeah, did you see Yuha last night?
No. You mean Professor anesthesia?
No, yeah, we had a live show with him this morning, a few hours ago.
I didn't know. I
Yeah.
really like him. I went to visit him in China.
No, he's going to do more. He's going to do more.
Cool.
But yeah, it's on the front page now of Neurosurgical TV, the recording of Yuha last night. But there were a lot of big neurosurgeons there, big ones. Vlad, I'm not a neurosurgeon. Vlad, he's a big name in Skull Base, I think. But anyways, there's going to be some big names lecturing every day.
Oh, every day. Well, so you should get the poster on time so we can connect.
Yeah, well, we have. Do I have your email? Because if you're on the email list, you usually get notified when there's a conference.
Okay, I will shoot you my email.
Yeah, that was a great lecture, man. I wanted to make sure that got well done because, you know,
thank you.
I think you could send it to young neurosurgeons and residents, and you know, because that's a hot topic. I'm not a neurosurgeon, but I know it's a hot topic.
Yeah.
Yeah, and seeing
as I mentioned,
seeing
a
the
lot of
equipment.
people now they're really looking to use the endoscope because really it's like playing video games.
Yeah.
A lot of young neurosurgeons now, they're really comfortable with video games, very comfortable with watching just the screen and moving automatically the hands. So.
Yeah, I'm glad I could save that. So let's hope everything turned out good. Okay, thank you, everybody.
Okay.
Thank you.
Thank you.
Okay,
Bye.
you guys can stay here. You don't have to go. I can leave the room open if you want. Let's see here.
I'll send you my email.
Yeah, okay, make sure.
Mhm.
Hello, everybody. Did anybody, okay. Well, I guess I better hit the road here. Okay, bye-bye.